believe we're at section 1432.
That's what I have too. I have that we paused here.
And we do have some comments from Dr. Arguello, who up until I believe it was up until yesterday was able to join us. So we have some notes and comments from him. But again, Kristen, I'll throw it over to you to start the discussion and see what revisions we can make in 1432. And when it's appropriate, I can read out Dr. Arguello's comments and concerns.
Okay. So in looking at this, I think that the last time we had agreed to take out is it section A, history of recent trauma, and just say history of trauma. And I believe that was the only part that we had changed. Was there anything else that anyone sees in here? I also wanted to point out it looks like there was a recommendation from the SYTF subcommittee to require that all SYTF youth receive screening for trauma. But I wanted to point out that it's noted within this section that screening for trauma occurs for all youth. So I guess I don't think it's necessary to call out just SYTF because it's included for all youth. So and will you scroll up again? I had forgotten that we added a number 4. Diagnostic and treatment plans for each condition identified in health assessment are developed as clinically indicated in accordance. Okay, yeah. Were there other recommendations that we wanted to consider from Dr. Arguello now?
I'm going to be honest with you. I'm having a hard time processing them. So maybe I can just sort of attempt to paraphrase them. I know we discussed the initial screening for mental health and substance use disorders done mainly as a health assessment. And a history and physical may not be performed if previously done in the last 12 months. So the current process, he believes, has limitations as the information may not always be sufficient to identify a further mental health, behavioral health screenings and assessment. He's recommending that there is a need for exploring alternative approaches for comprehensive and accurate assessments for youth. Concern about young people in facilities waiting for adjudication and youth in SYTFs. He's recommending using a validated screening tool for mental health and behavioral health with Fidelity as part of the health assessment process. Workload increase would be minimal since most of the instruments are self-reported. So that might be something contained in section A. And I know that, and I'm just asking Kristen and Amanda especially, this health assessment, is that separate from a mental health assessment in another?
Yeah, because I think that this health assessment, this is the 96-hour exam. This is what happens within 96 hours of a youth entering the facility. It's like a whole systems check. And within that, there is an aspect of mental health, but I believe that the mental health assessment, like he's discussing, would be in the mental health section, right? That would be called out
1437
in more detail, and I think probably more appropriately in the mental health section so that we can talk about tools there. I also wanted to address the 12-month piece. I see where he it's number 2, youth admitted adequate action done within the last 12 months, right? There's no reason to believe that no. So, I can talk about at our facility, for instance, we have a mechanism in place to update the information. So I think it would be fair to include language in here to that effect, that if a youth enters the facility within that 12-month period, that there is screening done to update the information that's already on file.
Physical examination and laboratory diagnostic testing may be modified for youth admitted with adequate examination. So it seems like it's almost saying that, but maybe it could be made clearer. I think probably the intent of that language may be modified is updated, but maybe it could say the physical examination and laboratory, and I'll read it back. Just want to get a sense of what members think. The physical examination and laboratory and diagnostic testing components maybe should be
I think it would
updated,
be better to say should be, will be, should be, will be,
shall be,
must be.
must be. So instead
Shall
of,
be updated. I don't like the word modified.
me neither.
I think shall be updated as appropriate.
What do other members think about that update?
Yeah, I think updating and shall be updated makes the most sense. Because we know youth sometimes return within 12 months, and sometimes things are drastically different, and sometimes they're not.
And I think his second point about, I think I heard you say he wanted language in there regarding youth who are incarcerated beyond that 12-month period. But number 3 addresses that. Physical exams shall be updated annually for all youth.
Okay. And I think just reading through that, making that shall be updated. And again, I know I've probably said this 475 times, but once, as long as we get the flavor and the intent of this, the membership, when we as staff are going back and review, we might make tweaks to make things sound a little bit better. But I think that changing shall be updated as appropriate. I think we would want to put a period after 12 months and then take out provided there is reason to believe, because that kind of was
Yeah,
talking to the other thing, the may part. So I would just
Yeah.
take out, yeah, perfect. I love it. Sorry, I was like, that was like my, I'm just very comfortable with being happy with those changes. Forgot I was at work.
Mm. Okay, was there anything else?
I don't have anything else.
Linda, Meredith, any comments, or are we good to move on to the next one?
I don't have any comments. Thank you. And apologies for joining late.
Oh, no worries. Thanks for being here. Okay.
Okay, are we ready to move on to 1433, requests for healthcare services?
Yes.
Okay, so there's one recommended change at the beginning. Age and linguistically appropriate materials to inform youth of the availability of healthcare services and develop policies and procedures. Is there anything else? Anyone have comment on the recommended change and any other changes that they'd like to talk about? Oh, Meredith? Is your hand up?
Yes, thank you. I was going to recommend that, I'm wondering if it's possible to just zoom out a little bit so we can see a little more on the screen. That's awesome, thank you. Under E, where it says, provision shall be made for any youth requesting healthcare attention, or observed to be in need of healthcare, to be given that attention and care, by licensed or certified healthcare personnel. Thought that word attention was just not very specific. And then the last thing I was going to suggest, is that we have, in, is it 1402, this mention of, the ability or the right to seek, or to have, community, like a choice of providers in the community. So, it seems to me like this is the place to make sure that that right is then turned into like an actual access. So, I wanted to suggest that there be a G here, that youth shall be informed of and provided the opportunity to contact and receive healthcare from a community-based care provider.
How does that work in practice, Kristen? I appreciate that suggestion. I'm just curious about how it actually works in practice at the facilities.
So I can talk about us, what we do here. We, we send a fair amount of kids out for specialty care. And it isn't common. The most common time that we've had a youth seek their own doctor is during pregnancy. And we arrange and facilitate those appointments with the outside provider, and we often have to make sure that the office can accommodate the way that the youth arrive at the facility. But if youth, sometimes youth have their own providers, and assuming that we can work with that provider again to accommodate how the youth is arriving. Some youth come in, braces in this age group is a big thing. So if they require orthodontia ongoing, we would coordinate that with their providers. We do have to, reasonably help the youth understand that, arranging their own appointments outside of us is sometimes more difficult because we are tasked with having, maintaining that contact, not approving the appointments, but confirming them, arranging with transport staff. So it goes a little bit beyond just the youth choosing their own provider. There's a lot of facilitation and coordination that occurs. And sometimes appointments are not immediate. So does that help?
Yes, that was very helpful for me. Thank
Okay.
you.
Okay.
Well,
And
and
it's-
from,
Oh, go ahead. Sorry, Amanda, go ahead.
I didn't raise my hand. It seems to me that it more happens with specialty care. Things like orthopedics. Kristen mentioned orthodontia. And yes, it is quite of a coordinated effort. So it seems reasonable that just general healthcare, screenings, etc., and specialty, following up with specialty providers. We've had youth who've had very specific medical conditions that then those appointments were coordinated for continuity of care.
Yeah, and that's something that happens often too. Like if we have a youth, for instance, who's diabetic and followed by a specific doctor in the community, we're going to maintain that relationship because they're going to be released back to that community, and that's going to be their doctor. So, so yeah.
Great. Any other comments, or if we're good, we can accept these changes and move on to section 1434.
Okay, 1434. Consent and refusal for healthcare. So are there any, it doesn't look like there are any recommended changes.
Great. So we'll leave 1434 as is.
Fourteen 1435 is specific to dental care. Any recommendations for this section from anyone? Meredith?
I did have, well, some questions, and, also wanted to reference the National Commission on Correctional Healthcare. So one question is, it seems to me that the care standard is, for dental exams, including cleaning and clinically indicated care, should be, semi-annual, not annual. And I would propose that that be for any youth detained for longer than 6 months then. So this is editing the last line. So it would be semi-annual dental exams. And I don't know if dental exam, like the word exam, is a term in the field, but to me, it seems too limited. To me, exam just sounds like more of a assessment. And so I would say semi-annual dental exams, comma, cleaning, comma, and clinically indicated dental care. And then moving up to the first paragraph. So the National Commission on Correctional Healthcare has a standard for oral screening to be performed as soon as possible, but no later than 7 calendar days from admission. I'm curious from Kristen and Amanda, what your experience is with the initial oral examination.
So typically that's done upon entry into the facility. So again, I can speak to what we do here, and that is part of the health assessment that's done when the youth arrives at the facility. We're fortunate we have a dentist on site that's with us every other week. So if one of our staff, one of our nurses, our nurse practitioner, our doctor, or the youth reports having some issues, or we have any reason to think they have issues, we can put them on the list to see the dentist. It's been just within the last probably 10 years that we've had a dentist on site. So I know for facilities that don't have a dentist, that assessment would be done at the beginning because it's part of the health assessment that's done, just a whole systems review when the youth walks into the building. But for facilities that have to schedule those appointments outside, 7 days might not be enough time because we can't control the scheduling with outside offices, right? It's different when you have someone on site, but not all facilities are fortunate, like Sonoma County, to have someone in-house to do those exams. So I would be hesitant to put that strict of a time frame on it because there's a lot of factors that would impact the ability to stay within that.
I think maybe the National Commission balances that by allowing for kind of similar to the way that our regulations do around the intake assessment versus the full Amanda, you have these words, the intake screening versus the full health assessment. So the National Commission calls for a screening within 7 days to be done by a dentist or qualified healthcare professional who's received documented training approved or provided by the dentist, and then an examination performed by a dentist within 60 days of admission. So that it looks like that's how the national standard sort of balances the needs that you were talking about.
Yeah, again, if you have a facility that doesn't have an affiliation with a dentist, I just feel like being so regimented within that time frame, it would be difficult to achieve that.
Well,
So
it seems to me that if you don't have a dentist on staff, then you should have somebody who's then received training or guidance from a dentist to do that initial screening for urgent dental issues, which I'm aware present at juvenile facilities with some regularity. I would be concerned to think that there's a child with an urgent dental issue that's sitting in a juvenile facility over a week in the care of the government, but not having that attended to.
Yeah, I'd be, Amanda, your hand is up.
Well, it kind of sounds like what we're talking about is the difference between just a generic screening for conditions in the development of the full assessment plan versus an urgent condition, of which then there should be, I think, some process. That's I guess that's my concern, is setting the time frames for a general outpatient, let's just say outpatient screening versus an actual appointment for an urgent condition.
Mm-hmm.
I think what I'm talking about and what I'm seeing in the national standards is slightly different, which is 60 days for an oral exam by a dentist, but 7 days for a screening that I think would be intended to, obviously, if the timeline is shorter because it's intended to catch more urgent issues than that need to be addressed before the full oral exam by a dentist.
So I think the way I'm reading this section, develop and implement written policies and procedures, require dental treatment provided to youth as necessary to respond to acute conditions, which are urgent, right? That's needs to be addressed right away, and to avert adverse effects on the youth's health. that's the guideline to allow facilities to develop their policies and procedures and to put those timeframes in there. I hear what you're saying, Meredith, that nationally there's been a standard set that happened within 7 days, but I'm reading this that the guideline is what we just read that allows facilities to establish their own policies and procedures around this. I like the change of having it be semi-annual. Because that is community standard, and that's typically if you're in the community when anybody would go, right, and have their checkups at the dentist. So that's just my opinion.
If we can't reach consensus, then I would propose that it be put into a comment to the ESC, my proposal to align with the national standards. And I can give you the language, Amanda.
Can I ask a clarifying question about that, just so I understand? Would the 96-hour assessment, health assessment in the last section fall within the 7 days that you're talking about for the assessment?
Yeah, so typically my experience has been that 96-hour exam involves a complete systems review to include dental issues. But I think what I'm hearing Meredith say is a little bit different, that within 7 days, there should be an assessment by a dentist or somebody trained by a dentist to do that assessment. Do I have that wrong, Meredith?
The national standard is dentist or qualified healthcare professional who's received training approved or provided by the dentist, which is not specific. But I would think anyone who's doing an oral screening would need some amount of specialized training beyond, you know, the whole reason we have dentists. You don't just get dental care at your doctor's office. So Amanda, to your question, I think it could be encompassed within what happens within the 96 hours, provided that the person who's doing that screening has some amount of specific training as to oral screenings.
I think it sounds like what I'm side-eyeing Forrest, who's next to me. A concern would be in agencies that don't have access to dentists. And again, I'm just trying to think about, they might not even have access or somebody on site that's meets that a trained qualified healthcare professional. Is that really the concern, that there might not be an ability for agencies to do this because of their location or resources?
Are you asking me that?
I think I'm kind of asking Forrest, from his travels around the state, and also Kristen, just to summarize your concern. I don't think there's any concern with the concept. It's just being the ability of agencies to have access to a qualified trained person to do that.
Yeah, so like the example I can give is for my staff, we have our dentist here. We have him, come to our staff meetings. He provides guidance on what to look for during that initial screening. This isn't a problem for us. This is part of what they're doing within that 96 hours, right? But I don't know how another jurisdiction would meet this standard who didn't have that. And I understand the concern that you're raising, Meredith, that we should mandate that they have that, but I don't know how to make that a mandate without resources everywhere. That's my only concern, is how would all jurisdictions be able to meet that standard?
Well, because it seems minimally for folks who don't have dental on-site dental services, at minimum, one of the nurses would have to be trained in some sort of dental screening, specific, not just a general, and to kind of cover that training piece, or that, training of designated or designated staff with specialized training would be the only other way around that for folks who don't have dental. And I'm not exactly sure for folks who have contracted nursing,
Mm, yeah.
how that would work for them either. So because on one hand, then we're having to trust that urgent and emergent needs are being prioritized. So I'm not exactly sure how we're going to navigate through this, other than to put in the recommendations as noted, and then let the larger body of the executive steering committee weigh through that one.
And just another thinking out loud on my part, we can also get some information from our agencies as we're out and about, and just kind of get a sense of who, we don't want to set up a regulation just to make it possible for everybody to adhere to, but it would be helpful to know what the ability is across the state for agencies to meet that. I'm just, I haven't been out in the field very long, but dentists are not always present at the facilities. Not that it shouldn't be, an urgent need. So one of the things that we can do is, as Meredith suggested, make sure that the ESC knows that this is a recommendation to add the NCCHC guideline, best practice, and we can do a little bit of research as we're out in the field and just kind of see what that access to dental professionals and trained people is. And I see you have your hand up again, Meredith. Go ahead.
I was just gonna just bring back up the second part of the NCCHC standard, which sounds like it doesn't have the same staffing concerns. This is the standard of an initial oral examination performed by a dentist within 60 days of admission. Since that is a longer time period and allows the facility to arrange for that either on-site or off-site, I think I would still recommend that part be included. There's one more piece that's in the national standards, which is, and I didn't see this anywhere else, but we already had someone mention orthodontic care. So I would propose, per the national standards, that policies and procedures shall include the management for youth, of care for youth who've received orthodontic care in the community prior to admission.
Meredith, would you, not right the second, but when you get a chance, can you email the language to Amanda and me? That would be really helpful.
Yes, I'll just send you everything that I am.
And so did I hear, were you saying that you would change the 7-day recommendation to within 60 days of admission?
The national standards are for both. So just to clarify, 7 days for the assessment, which I agree could be part of the 96-hour assessment, with the intention that the person has some dental specific training, and then 60 days for an oral examination by a dentist, and that's the national standard. And then
I think
policies for orthodontia.
I like I think it would be important with the orthodontia to spell out what Meredith said in terms of if care had been initiated in the community. And then I'd like to add, if we're going to consider the 60 days to have an exam performed within 60 days of admission, a line that says, unless, documented health records show that an exam has been done within, that 6-month period. Does that make sense?
Yes.
Yeah, because I think that
I'm just wondering if the 60 days is something that we think we could actually make as a group recommendation.
Yeah, I was gonna, also just to summarize, I see Amanda, putting that language up there. So keeping that, the 7 days, which may or may not be captured by the, uh, 96-hour health assessment, but moving the 60 days for oral examination. And then once we have the language from Meredith, we'll clean up the language. So that's the concept there. And then adding, orthodontia. And I heard something about care being initiated in the community. Perfect.
So are we just saving the 7 days, this first line for ESC consideration and including the other two now as a group? Is that what I'm understanding?
That's what I heard. Yeah, looking around the Zoom room for consensus. Thank you, Amanda F.
And if I could just add about, I know we talked about the smaller counties. I do have some of the far north counties, and typically, we see a regular schedule of when the dentist may come to a facility. They most often do not have them on site. For that matter, there's even agencies that don't have behavioral health or medical on site. It may be sometime they share a parking lot, with health services, and they'll come over and assess when intake arrives, or, kind of as needed, I guess you could say. But many of the smaller counties, are kind of limited in their resources, but they tend to have a scheduled, dental care services that they provide. But again, I can also reach out and get some specifics about how, what the typical practice tends to be with some of the smaller counties.
Okay, are we done with this one and ready to move on to 1436? Yeah?
Yeah.
Okay, so 1436 addresses prosthesis and orthopedic devices. Regarding the provision or retention or removal of medical and dental uses, including eyeglasses, hearing aids. Health of the youth would otherwise be adversely affected from the procedure of retention or shall come. Does anyone have any comments, observations, recommendations for this section? No?
I was just gonna ask about I mean, it's a little weird to have eyeglasses and hearing aids called a prosthesis, but I'm curious, Kristen and Amanda, about contact lenses, how often that issue comes up. Does that fall under here versus like, prescriptions, or how do you all handle that?
So I know for us, we do send a fair amount of kids out for glasses, but we're sending them out for glasses and we're not typically opting for contacts within the facility. Now, if a youth comes in with contacts, we will certainly facilitate that and allow, maintain those supplies for them. But the only time we've opted to go to contacts versus glasses is when the diagnosis for a specific youth was for what's called hard contact lenses, and the specific diagnosis that this kid had, only those hard contact lenses would address the issue for her. So, but typically it's going to be glasses unless they come in with the contacts and they already have them.
And as far as I'm concerned, I don't have a lot of information about how that works here, other than when Kristen said we've had youth who come in with contact lenses. But I'm not even sure what provisions are made for them to continue the use. So I can't speak with any authority on that.
Thank you.
So anything that anyone wants to see added or changed in this section? No? Alrighty. Okay, so moving on to 1437, mental health services.
And this is where Dr. Arguello's comment about screening for, I'm reading section A, screening for behavioral mental health. I would change the word problems right off the bat, where something more validate, something, a word about validated assessments being used. I know a lot of facilities use the Maisie. There's a couple of other tools out there. We certainly don't want to mandate what tool that a agency uses, but is it feasible to add that that screening is done using a validated assessment tool? And what's a better word than problems? Screening for behavioral mental health
Symptoms?
symptoms, way better.
Can we take out the word altogether?
Yeah, screening for behavioral mental health. I mean, we all have it, right? We all have screening for, what do people think about that? Screening for behavioral mental health.
So this is section has a lot of language that is kind of specialized.
Okay.
But I guess I need to know in general some of the backstory and the purpose of this particular section, how some of this stuff was created. So screening for behavioral health issues, concerns, symptoms, I think
Symptoms.
were some of the language that I just heard, the needs. I mean, I think that's where I have questions about
Yeah.
this is again a large general category. So what I'm in reading is that all youth who come into the facility should have a screening to identify immediate, urgent, or general mental health, behavioral health needs. Is that how other people are reading this section as well?
Yeah, I think, sorry, I didn't look to see if anybody's hand was up. Kristen, were you gonna speak? Sorry, I just jumped in.
Yeah, I think because if you continue down screening for behavioral add intake, history of recent exposure to trauma which may require immediate attention, including physical, sexual abuse, sexual assault, neglect, violence in the home, traumatic loss, current traumatic stress symptoms, and pregnancy needs. I don't know why pregnancy needs is included in that section, but I wonder if this, the intent was like, what do we have to do immediately? Is there something, that we're looking at right now? And maybe there needs to be, because then the second B, assessment by a behavioral mental health provider when indicated by the screening process, right?
Yeah, and I see, I jumped up to the very top statement. I think it's even bigger than that. I think that it's policies and procedures for what services are provided, and then the elements are screening, assessment, identification in C, it would be like the identification of services provided, what, and then D would be,
Mhm.
so that's how I see it, like each is a separate issue.
Yeah.
And I would just looking, I mean, just the way my brain works, I would completely rewrite A a little bit to make it clear that it's, that first part is an intake screening
Mhm.
in addition to the 96-hour health assessment. So A is, like the baseline really establishment for what needs, behavioral mental health needs the young person comes with, including, the trauma, and immediate assessment. Yeah, the pregnancy is interesting unless it's related to some of those laws around loss. So that's my thought. I don't know if that helps at all. So like I would rewrite it to say these services shall include but not be limited to screening at intake for behavioral and mental health needs. I would say needs, but I feel like there's a better word. And then I would almost start a new sentence, this screening. Oh, no, you're fine. I don't want to just keep talking. I so appreciate the being able to see it for behavioral health needs. And then put a period at the end of needs. And then I would say a new sentence would be this screening shall be performed by behavioral mental health personnel or trained youth supervision staff using, and this is where I don't know, I'm kind of like jumping into the role of Dr. Arguello, like using a validated assessment tool. And I don't know if that's where that should be.
And I think that that's fine, but I would say
Okay.
that using a validated screening tool.
Screening tool. Gotcha. Because it's screening, not assessment. That's a really important clarification. Thank you.
Yes.
And then that would be the end of that period. And then it would start the next sentence, the screening shall include, and then anything else that looks delightful. And I see Meredith sorry, I'm just like my self is popping through a little bit. It's horrible, right? I use words like delightful all the time. Meredith, I see you have your hand up too.
I'm just trying to make sure I understand how this section overlays with, the screening and assessment sections we've already done. So
That's a
is
good point.
is that the intake that happens within 96 hours? And then B is an assessment when indicated by the screening. I'm confused by that because it seemed to me that when we had assessment for all other health issues, it wasn't like there wasn't a gatekeeping aspect to the screening. Like the assessment didn't depend on what was found at intake. So I don't know why we wouldn't have an assessment for behavioral and mental health, given that we know there are disproportionate rates of those issues among youth in juvenile facilities. So, and I'm also looking at the national standards where it's very clearly intended to be health staff, not youth supervision staff. I think that that's really problematic here. And so I would change that so that it is qualified personnel or qualified healthcare professionals who've received training.
But if you're using a validated screening tool that sometimes includes it or is specifically only self-report by the youth, and then that's the screening that you're using, the full-blown assessment comes where it says B. the behavioral health provider comes in and does that full assessment, taking into consideration what came through on the screening. So it is common for youth supervision staff within facilities to be trained to administer tools like we're talking about, and appropriate, totally appropriate.
Well, we changed the intake to prefer health professionals unless not available. So at a minimum, I would recommend that we align them.
Amanda, your hand is up.
Yeah, in the documentation guide for Medi-Cal, for it defines the screening as any where did I write it down? It's designed for non-clinical administration. And so that's where it captures the trained youth supervision staff. So the Macy that Allison had mentioned earlier is a self-administered report.
Mhm.
And
And
then
it's designed for this population specifically.
and what happens is then you have, Meredith, you have two different indicators of a high score and a low score that set the timeframes by which, or our facility here had then set timeframes by which behavioral health staff was required to follow up with. So trained clinical staff were high Macy's were within 24 hours, and then low Macy's are within 5 days. There's always behavioral health staff that are available to meet with youth more urgently than 24 hours or more urgently than within 5 days. But unless we're going to change the word screening, inherently it's allows for non-clinical staff administration.
So the
don't-
language we put into 1430 was shall be performed by healthcare personnel, or if no healthcare personnel are available, trained supervision staff.
And Forrest has his hands up, but also, I mean, it's kind of part of what the intake process, it's done in part of the intake process, right? So they're doing for risk assessment, the DRE or dry, and I never get that part right. So there's multiple things that they're collecting data and information on at that
Yeah.
point as well.
Right, and there's screenings that just probation staff are doing that inform the behavioral health processes, at least in our facility.
Yes, and so in number one, or not number A, and I believe that was Dr. Aguelo who was saying using a qualified tool,
Mhm.
perhaps it should be tools including, a qualified tool including but not limited to ... because as we know, screening is also just things that's observed, right? So I wouldn't want to just limit it to, make the assessment using a qualified tool, but including but not limited to, or something to that degree, so that because the intake staff, the detention staff are observing and
Mhm.
trained to observe certain things, and they may not be qualified. So as we use qualified personnel with some of the intake screenings, it's like we have to be careful not to leave out the youth supervision staff who are observing things, although they may not be qualified, from the medical standpoint.
And I like that that caveat for us, because that observation piece, because it happens, and Kristen knows, the youth says, I don't have any mental health problems. I don't have any substance use problems. I'm fine on the paper. But when you meet with them, they're a mess, and they they need something much more urgently than they are. So it does allow and our policy is that if we don't get a screening because the youth refused, or there's even a problem within the electronic system, that we treat it as a high and see them within 24 hours anyway. So I think that observation piece is important. And I know some of the other recommendations, the community provider recommendation or the community comments going way back to original was they wanted a mental health provider to do the screening.
Meredith?
I think the kind of observations and, collective, information gathering that you're talking about is one thing, and that's very different than a mandated screening using a screening tool. If a facility wants to include additional observations to help with this, identifying of youth who should have a further assessment, that seems permitted here. But I would be very concerned if the suggestion is that somehow that is the same as what we're talking about here, which is, or somehow replaces, or somehow this requirement for a screening needs to incorporate that kind of observational or collective information gathering process. This is, to me, and Amanda, is what I heard when you were describing the medical process. It's a very specific formal screening using a tool. It's not information gathering based on observations alone.
No, and I wasn't suggesting that we replace the observation with that their screening be replaced by the observation.
Okay.
It's almost like the observation can elevate,
Supplement, be in addition to.
right,
Yes.
irregardless of, like, in the instance.
Okay,
that
I think
described
we're seeing it the same way. So what at least on that point. So what I'm trying to additionally say is that as we've heard from people in the public, as we see in the national guidelines, as we already put into the intake section, there should be a preference for personnel with this expertise, and the fallback of supervision staff. And that, I think, to me sounds like it's distinct from the input that Forrest was describing and needs to remain as its own thing.
But the way it's laid out here, you don't think that's what this is saying?
No, I think this allows it. It doesn't incorporate the preference for health personnel to do this screening. It is agnostic as to who does it, and I don't think that should stay that way. There should be a preference for
specific to the screening tool. Because
Yes.
usually the screening tools, help me here, Amanda, where I'm wrong, but typically the screening tools, a lot of them are self-report by the youth. So the youth is completing that with the guidance of a trained staff person. So the assessment, the actual assessment, where typically a youth is going to have a treatment plan, a mental health treatment plan put in place, and they're going to be diagnosed. That is done by a licensed professional, and that is done by, specifically as B spells out, a mental health provider. But the screening tool that often is done at intake is a self-report by the youth. That's the way the Maisie is set up specifically for this population. So I guess I'm not understanding how, because the way that it's worded, performed by either behavioral medical health personnel or trained youth supervision staff, it is common that the youth supervision staff are trained to assist with those tools, but not with the actual assessment that's going to diagnose the youth.
Right. You know, I don't necessarily have a problem with what Meredith is saying in regards to it's preferable that the screening be done by a mental health provider
When health personnel is available.
or when health personnel is available. The first and to allow for trained detention supervision staff.
Yeah, did you see the addition that she just put there?
Because I don't want it to just fall onto being the behavioral health staff, because there's a delay. Youth report when they come into the facility and it may be midnight, and then the behavioral health staff will pick that up when in our instance at 8 o'clock in the morning. But if we had to wait till 8 o'clock, then there's a lot of hours that there could be an issue beforehand. So one doesn't exclude the other, and it notes the preference. And some facilities may have that option to do that and choose to do that. But they also could choose the standard screening tool with the detention staff.
I added when health personnel is unavailable to A while you were speaking. If I'm not sure if everyone caught it or not, but it's on the screen.
Yeah, I think that it looks like it captures what Meredith was saying. Do you agree, Meredith?
Because the way I'm reading it now, it doesn't not require that the screening be done by behavioral mental health staff, but could be.
Right. In most cases, that tool is used by the detention staff, intake, detention staff, and then as an initial, I don't know if that needed to be said, initial screening or initial assessment, and then forward it to the behavioral health staff, who may come in, the next day. So in most cases, I believe a lot of times that's who's completing that validated tool. They've been trained to complete that tool and forward it to behavioral health. So just wanted to put that out there. And I guess I'm really saying that because, and it may be getting into the weeds a little bit, but unavailable, sometimes behavioral health may be available, but that's just not the process. The process is youth supervision staff completed, and that's part of their process.
Before I scroll further down, there was discussion in a prior section about removing recent exposure or the term recent. Is there a similar feeling here, or are we leaving that alone?
I think you could take it out because with the rest of the language in this section, require immediate attention. I would just want to make sure that that remains in there so that, if there's any further reporting necessary or treatment needed immediately.
And I agree. And it's a little tricky because it's like, this is sort of a shall include. So I know that it's not, intended to be exhaustive, but we did have a comment from Nayeli last time, who I don't think is able to be with us, but the uh not having ACEs anywhere, this seems like the place to include. So I agree, maybe eliminating pregnancy needs as not being a behavioral or mental health need. And then the additional things that I'm seeing in the national guidelines would be psychiatric hospitalization and outpatient treatment, substance use treatment or hospitalization, suicidal behavior, self-injurious behavior, adverse childhood experiences, and recent stressors are all issues that screening would cover under the national guidelines.
Amanda, did you want to comment on that?
I wanted to comment back on the pregnancy needs. The only thing I could see would be like postpartum.
Yeah,
That is a kind of special and unique. But it could be captured in the rest of the things.
mhm. I mean, I'm fine leaving it. It just seems like an odd, kind of sticks out in that section a little bit.
Yeah, the postpartum would put it in a different context.
Well, postpartum and also, just there's a lot of things that could come up specific to that. I'm fine leaving it if everyone agrees. But it just sticks out to me.
Yeah, I'm okay leaving it. And then I think going back to what Meredith was saying, can we scroll down or was it up in the, I know we kind of moved.
It's still in A. There's
Oh,
in
okay.
parentheses here. So
Gotcha.
I think Meredith proposed adding to this. I'm more leaning on the side of getting rid of all of these examples, but I understand if we want to add to it instead.
Yeah, that's a good point. Not getting caught in a list and just leaving it with any exposure to any trauma that would require immediate attention.
Well, I mean, exposure to trauma doesn't necessarily mean symptomatic, and symptomatic doesn't, we want to address the needs, for sure, to avoid, to help mitigate and avoid it becoming a post-traumatic stress syndromatic condition. I mean, the screenings do include, in continuing to use the Macy as an example, and I don't have it with me to see if it gets, I don't know. I don't know. Because I think it's going to pick up on all of those. I'm fine leaving it kind of listed out there, because it is very broad. Physical, sexual abuse, neglect, violence, traumatic loss, current traumatic symptoms. Kind of inherently, those are the areas that are included in an ACE. So I don't know.
There was a discussion by the ESC when we were talking about definitions for behavioral health, and there was some adverse childhood experiences is being proposed to be added to the term behavioral health. Let me see if I can pull it up real quick. Share. And that came from, I believe it was Office of Attorney General's recommendation to include some of these additional behavioral health. And so we have adverse childhood experiences because there was a lot of discussion at some point around ACEs, and this is what we landed on. So that any time the behavioral health is mentioned, it's built into the definition. I'm not sure if that helps in terms of Nayeli's recommendation, or if it should be called out everywhere in the regulations. I think this was where we landed on it.
That's helpful to me that it's included in the definition.
So because it's included in the definition, do we need to spell it out in the screening portion, or is it
I
just?
think that's what she's saying, is that just inherently it's part of the definition of it, so we wouldn't need to spell it out each time.
Yeah.
Which is helpful.
And if there were some of what Meredith listed off that may be more appropriate for this definition now, having seen it, we can definitely pick it up then if you prefer.
I guess I'm still struggling with figuring out how A really works, because now A seems to really good at what requires immediate attention. And Amanda, I'm interested to know if like that is the scope of screening that really happens, just things required that need immediate attention. It doesn't sound like that's true. So again, now B, then the assessment depends on the screening, and the screening appears to be limited to issues that require immediate attention. So to me, these don't quite align with how folks are describing the way the process works.
I think, again, in a perfect world, the overall intent of this regulation is to encompass and describe and establish policies for the whole system of behavior and mental health services that are going to be provided at the facility. Not all young people need ongoing or crisis management. So the screening piece is that, I don't want to say just that because it's so important, because so many young people need those services. And again, I might be getting it wrong, but that A is to, outside of the 96-hour holistic top to bottom physical, mental, like whole package health assessment of that young person, this is a separate screening. And 90% of the facilities use something like the Maisie to just get that process started. And then, like Amanda had said, again, in my mind, it's like a continuum. If you're screened into, it might not be a crisis situation or an immediate trauma. It could be an ongoing, it could be, a history of depression or anxiety that would set up an assessment for ongoing care. So I think, I don't want to oversimplify how I see it in my mind, but it's that get the foot in the door. Set the baseline for what that young person needs. And then the next step is going to be, okay, what does that screening indicate? And again, that Maisie, which is self-administered, is validated, and it would put the kids into the bucket that need that next, or in line. We wouldn't put kids in a bucket. Put them in line for that further assessment by the mental health provider. Am I oversimplifying it? I mean,
So then I'm
hear-
confused again by what you're saying. So A seems to me the intake screening that happens at intake.
Mhm.
Am I misunderstanding it? Because then you reference the 96-hour.
I'm saying it's separate from, it could happen at the same time, but it's a, like, I'm thinking of it in terms of the Maisie. Like if I was being admitted to a juvenile detention facility, I would get it's separate from, even though the 96-hour assessment is going to include some aspect of behavioral mental health because it's just the whole picture of the young person. But
Mhm.
separate and above from that is the young person sits with somebody separately and they administer this Maisie. We're using that as, kind of a Kleenex tissue situation. There's a screening done separately and very focused on that young person's behavioral mental health needs. It might indicate crisis, acuity, and immediate care, or it might indicate this young person is on medication for anxiety and depression, and so we need to engage this next step. So again, oversimplifying it, like the kid could sit there for a day or two to get that whole 96-hour. That's going to include some aspect of mental health, of mental and behavioral health. But separate from that, somebody is going to approach that young person and say, okay, now we need to separately screen, not assess, because that's the next step, what behavioral mental health needs you may have. So I definitely don't want to confuse it, but it's separate from the 96-hour.
I'm more like the 1430, the section 1430 screening.
Stand by 1 second. I'm losing my
Um,
numbers.
One thing then I would suggest is for B, because it sounds like the screening is in addition to the assessment, the health assessment, I would say assessment by a behavioral and mental health provider when indicated by the screening process or health assessment. Or.
So I would say, I'm looking at 1430. And again, I'm gonna make things up and look over at Kristen and Amanda for their thoughts. And again, over the years, sometimes the regulations have been piled on top of one another. So when I look at 1430, that is when the young person walks into the facility. And again, it talks about, adjudicated youth being in there for longer, but to me, that, medical intake, that's almost like a separate piece of paper. That is an immediate assessment of, does this kid meet the criteria to come into our facility and stay healthy, or do they need to go get some other type of health care taken care of before they're cleared to enter the facility? Now, could these be written better so they flow better together? Probably, but think about 1430 as the agency has to have a policy and procedure that outlines what makes a kid, quote unquote, clear for being taken into the facility. No, and I realize it says medical, dental, behavioral, mental health concerns that are in there. It's almost like that's the physical part. And then further on and separate from that an initial, and it could happen one next to the other, is that the Maisie, the separate piece of paper that says, okay, let's figure out what's going on with your mental health. Amanda and Kristen, am I saying that right? It could be streamlined, but.
Yeah, well, so one way to think about this, Meredith, is 1430 is pointing at, like Allison said, the kid walks in the door, there's an intake screening that's conducted. We changed the language to say ideally by a healthcare professional if they're available, but that covers, like in our facility, it covers every aspect of what we want to know about that kid right when they're walking in the door. Are you on any medication? Have you had a cough for 2 weeks? Like it covers every aspect of that person walking in the door. That isn't where it ends as far as any other medical screening. Immediately and within 96 hours, a nurse is going, or a nurse practitioner is going to go and sit with that kid and do a full physical and a full health history. So according to what the changes are we're making here now, in addition to that section 1430, and the additional, health screening that's happening by a nurse or a nurse practitioner, there's also now going to be a requirement that a screening include the use of a validated screening tool specific to behavioral and mental health issues. So it's in conjunction with the intake process, but separate from, and we're anticipating better and more individual and additional information. Does that make sense?
Yes, so I mean, to me, 1437A is part of the intake process, and B, I think if we can include that edit that Amanda put in, I think that is appropriate because it's getting to the fact that there's other health assessments happening, and those also can contribute to
Absolutely. And it's the picture, right?
yeah.
You're getting a picture of that kid walking in the door from different sources.
I think that makes sense with this edit. I'm more comfortable. The last thing I would say is it seems to me that C, instead of where resources permit, it should be according to the treatment plan, which I know we spent a lot of time discussing. And that I don't see the treatment plan getting referenced. Again, it's like these pieces, like Allison said, like maybe happened in parallel, but they should be tied together. They shouldn't happen in separate. So I would say according to the treatment plan or in accordance with.
I want to make one, I wrote that down, but I also want to just not to say no, but I think you could eliminate the where resources permit, but again, think about this as the agency is going to list out what therapeutic and preventative services are available at the facility. So I think putting in accordance with the treatment plan here it is a little confusing to me because again, like each facility is going to offer therapeutic and preventative services that they have the capacity for having. Their overall policy and procedure isn't going to list therapeutic services in accordance with the treatment plan because that's individualized. So I don't think that belongs there. I hear what you're saying. It's definitely appropriate other places, but this regulation sets up the framework for what services the agency provides. That's my
And I
only.
think it's important to consider the reason that where resources permit is included in there, because not all facilities, and Forrest talked about this a minute ago, not all facilities have on-site mental health staff, right? So I think it's important to allow for that to remain where resources permit.
So I also want to take us one step out a little bit and look at the larger context. So screening is just the identification of the needs. Then behavioral health services embedded in reach, contract, whatever. Really, one of our sole purposes really are to address emergent conditions to keep youth safe from suicide and self-harm. So we end up having a couple of different contexts. So we have that mental health staff is available to help you stay safe. And then mental health staff is available for treatment. And depending on length of stay, those types of things, it's going to look a little bit differently. And I have some in G, there's a mental status assessment. So we're talking, that's where the language to me starts to collapse on itself. So operationally for us, someone comes in and they have a screening. And again, they're given a high score, low score. If there's no score, we've been put up to high. They're on medications. It automatically bumps up to a high, even if they assessed and the rest of it as a low. Our staff then upon receipt of that screening tool, go do an evaluation. And that's really more of a mental status exam. Are you safe right now? Are you okay? Do you have suicidal ideations? You have thoughts of harm? Is there something that we need to put in place immediately? Do we need to restrict your razor because you're a danger, right? We put in essentially safety considerations in the very beginning, and at which time we offer voluntary mental health services. And then we go to the full comprehensive psychosocial assessment. So a screening does not necessarily indicate, again, a youth's desire to participate. To me, it's the evaluation, irregardless of whether you want to participate. Even 6 months you've been here and you're not participating in ongoing mental health services, if you have a need for an evaluation, we're going to go in and we're going to evaluate your safety. So I think that this is kind of takes me back to the origins and the intent, and then the trying to come up with a very clear language of what we really expect and want to see facilities in how they address the current, emergent, and long-term mental health needs of the youth, because this whole section is really written as emergent care and keep people free from self-harm and suicide. In part with the purpose of then connecting to whatever treatment services are available within the facility, given the length of stay, and then referral to post-release aftercare services. Now, that didn't really bring any clarity to our conversation. It took us in a whole other area.
No, but it did. I mean, you framed it, right?
I have to say, though, that, I don't totally see that this is specifically just addressing emergent or urgent issues. To me, it looks like it's the comprehensive approach to mental health care. But I have to say, I think that's a problem that this work group needs to deal with, is that these were written for juvenile halls that were intended to be detention facilities. And now we're looking at 7-year stays. And so how are we pulling apart like the different, I don't know, standards you might apply to a place with, youth who stay very short periods and youth who stay very long periods. And Allison, I understand what you're saying about, like, this is a policies and procedures, so it's not tacked to individualized treatment plans per se, but we have an individualized treatment plan section that does require procedures for individualized treatment plans. And I do think that the therapeutic services and preventive services should be in alignment with the policies and procedures for individualized treatment plans. If the treatment plan of the facility indicates certain services, then it's not a question of where resources permit. If the plan says certain services, then the facility is going to figure out, is it going to be in-house? Is it going to be contracted? What will be the mechanism for it? But it doesn't strike me as like integrated to not reference the fact that you have treatment planning procedures under one section and then a subset of treatment planning here where it doesn't reference back there.
I hear you, and something that, I mean, this process has gone in a different direction than we had started with, and in a perfect world, and that's something that's in the back of my head, we could absolutely streamline all of those sections together. Because I believe that though, the individualized treatment and making sure that you're providing those services for young people, that is going to be included. I hear what you're saying, like it should be much more integrated into one regulation. What about something, again, going back to the intent of this section, and Amanda, I see that you have your hand up too. What about to speak to your, I guess, the concern that the facility is responsive to the young people that are in the facility? There's something like, an annual assessment of the needs of the youth versus the services provided. And again, the way my brain keeps going is, there's two ways that services are going to be provided. Either the facility has the ability to provide the services, you could name what those services are, CBT, DBT, so on and so forth, or the facility is going to contract out and send the youth to the community. So again, maybe there can be something like an annual review of behavioral health services. Versus, I realize it's integrated with the behavioral and mental health services are integrated with the young person's individualized treatment program, but they might not always be the same. So I feel like I'm babbling a little bit. I'm going to call on Amanda Y. Hopefully she can figure out what I just said, because in my mind, I think your concerns are addressed elsewhere, and maybe there's a way to tweak this section so there's an annual review. Amanda.
Yeah, because I keep getting hung up on the treatment plan. And in my world, that's individualized to mental health needs. And because our services mirror treatment services in the community, unless you're getting very specific services, CalAIM does not require a treatment plan. Now, I know the youth have a treatment, their individualized rehabilitation plan. And in our world, that's a little different than what is indicated in a mental health treatment plan. And I'm wondering, because I agree, Meredith, my characterization of it being primarily for emergent conditions is not accurate, because it is fairly linear in what it talks about in the screening. And this is where I'm thinking, based on the screening, if there was a mental status assessment, or a mental status exam, because that's my issue with language in G, because the assessment is different than an exam, or an evaluation, mental status evaluation, that is kind of addresses that very urgent conditions. Is there something going on now? Or is it something that is a longer term treatment issue? So I don't know if there actually needs to be a delineation between the screening, evaluation, and then the comprehensive mental health assessment then that identifies diagnosis and specific treatment needs, and then separate out the crisis interventions and more urgent conditions into a different kind of its own section.
So I just want to add here, I appreciate what you're saying, Meredith, because I wonder if we can add a line in here specific also to what the SYTF subcommittee is recommending in terms of a prioritization of mental health support for a long-term stay, because I actually do see that as different, because we have kids much longer and we have an opportunity to provide treatment that is voluntary. I just want to add that in there, that we absolutely can't force the treatment, but I do think that it would be important here to spell it out, so that facilities have an opportunity within their own structure to take into consideration kids that are there longer term, right? Because, all of the other ones, I actually think the crisis intervention and the management of acute psychiatric episodes, stabilization of persons, I see all of that needing to be included separately, because that is, I mean, let's face it, that is a lot, at least my staff here, that's what they're spending a lot of their days doing. Not necessarily with our long-term youth, but with a lot of the rest of the population. It's a lot of crisis intervention. It's a lot of behavior modification. It's a lot of, support for kids that maybe haven't been here before, or are just finding out, oh my God, I'm going to be here for 2 weeks. I've never been here and now I'm here for 2 weeks. Do you know what I mean? So I agree with Meredith that the longer term youth that are here that we're seeing being sentenced for longer terms, it is a separate section on here by way of mention. And again, giving facilities an opportunity to work that into their policies and procedures within the resources that they have, whether it's in-house, in the community, whatever, provided by a CBO coming on site, county mental health. Because
May I-
what's gonna come out of that initial screening for some of our SYTF youth is gonna be different than what ultimately ends up getting worked out for them, just based on how long they're here and what their needs are assessed to be when they're here longer. Does that make sense?
Because Allison, go ahead.
I think I have a delightful suggestion. It kind of just stuck into
I
my.
like delightful things.
So do I. What about looking at C, therapeutic services? And again, this is back in my brain about like, what's the menu of services provided at this facility? What's the list of services? Therapeutic and preventative services according to the needs of the current youth population. And again, you could expand on that by saying, that I want to say in practice, there's a constant assessment of what the needs of the youth are and what services are going to be provided. But instead of tying that originally, Meredith, you were saying like, according to the treatment plan, that according to the needs of the current youth population would kind of expand that so that, you get a kid that needs this type of service. 9 times out of 10, the agency is going to figure out either it's in-house or contracted out to get those services for the youth. Am I off base, or does that kind of help align the regulation with that concern and tie it more to the youth's needs? That may change over time, especially if they're staying longer and longer and longer and have more acute needs.
Well, what I see, and I think you may have been directing that question to Meredith. However, let her jump in a minute. But because I heard recently there's a county who is not even sentencing youth or even recommending youth to secure track. So I think we have to encompass, and so let's just say that the probation department and the court sentence a youth to 1,080 days. Well, they're not secure track, so we have to treat them, and the longer they're here, they're actually become more stable because they often participate in programming, they mature, those types of things. So I wouldn't necessarily want to limit the long-term treatment that we're talking about to only to secure track youth.
No.
But it would be to incorporate anybody, because what Kristen was saying is very true. You have a a youth come in here, it's a crossover youth, they
Yeah.
have this long history of CPS and they've committed some sort of crime that's related to their dysregulation. Now they're in the juvenile facility, and every time there's a fight and every time there's a room confinement, mental health staff is going to evaluate them for their own safety and concerns. So
I wouldn't suggest including language that only calls out secure youth track. I think you're absolutely right, Amanda. We have kids here serving straight time. We have kids here who haven't even matriculated all the way through the judicial process yet, right? They've been here for years and they haven't yet realized what their ultimate outcome is going to be. So I definitely don't think you limit it at all by calling out only secure youth track. I think I'm not sure that according to the needs of the current youth population, I'm still sitting with that for a minute.
to me, that means it's really more about the therapeutic and preventive services according to the needs identified in the comprehensive psychosocial assessment. Because that's where you're going to get a diagnosis. That's where you're going to get all of the indicators. So if somebody does have PTSD, they need some very specialized, very specific type of regulation and trauma treatment. Other conditions have those things as well, and that I think gets us past the language of the individualized treatment plan, because it's been identified that they have a need.
But do you really have to spell that out when you're describing that you're going to provide therapeutic and preventive services according to the needs of the current youth population? You're going to assess that, yes.
Yeah.
But
Yeah.
I don't know that you need to call out. This
But
might capture it. This might be enough. What do you think, Meredith?
I liked what Amanda was describing. Is there, let's see. Like, I mean, to me, it's like it's like a nice step by step. So there's screening, then there's assessment, and then services according to the needs identified in the assessment. Is that kind of how you were thinking of it, Amanda? Because that satisfied the logic needs of my brain. And again, I would take out where resources permit. I feel like we dealt with that when we talked about how the facility is supposed to make plans for its programming. So I would again take that out, but I think needs identified in the assessment maybe seems a little bit more, what's the word? It's more clear to me than like the idea of current, what does current mean? So that it feels a little bit more precise.
And to me, I get stuck on the current youth population. To me, that's like everybody, not necessarily individualized. And agree to take the resources permit, because it doesn't necessarily set the time frames, but it does say the facility will develop systems in order to meet the therapeutic and preventive service needs of the youth. And to me, we're talking about the logical part and the flow of it, the screening, to me, then the evaluation, i.e. like the mental status evaluation, which really does capture, is somebody oriented? Are they suicidal? Are they having psychotic types of symptoms? What is their mood, their thought process? Again, and that's then also an opportunity for us to ask if they do want to, once we've established their safety, and we explain what services are available to them and how to request services at any particular point, then we also then at that point offer them services. So that then logically takes us to the comprehensive psychosocial assessment part. of which then treatment comes. That individualized treatment. Because there's the only reference to mental status assessment, and again, the language in G is, to me, problematic, because you don't necessarily want a mental status exam is not just for suicidality. It's a big part of it, particularly in this setting, but you're also assessing for psychosis. And
I guess the way I read that though, Amanda, and maybe we do need to update the language, is that this is spelling out that a youth who is in crisis and requires maybe a 5150 evaluation, maybe that's the better language to put in here, that's going to happen by a licensed person. That's not going to happen by an intern. That's not going to happen by someone who's not actually trained to do that. So that's how I read this section, that you have to have licensed staff on site that can provide this level of assessment for a youth that is potentially in crisis that is unmanageable within the facility.
right, and most counties have designated crisis people who have detention privileges, who have been trained and authorized by the county to place someone on a 5585 or a 5150 hold. Not everybody. I can't do it. I've not been designated by the county to do so.
So all of my staff are trained to do that.
Mhm.
So
each facility and each,
yeah.
and a county might not, authorize a contract staff to do that. Our protocol is, if we have identified that there is an emergent need through my which could be my bachelor level staff, if we can't keep someone safe, we're going to send them to the general hospital for that comprehensive crisis assessment
Right. So
by the
that
designated staff.
right. So within this guide, that's how your county is addressing this piece of it. So if we need, like, I agree with you, if it would be better stated, specific to, a 5150 assessment, but I feel like the language is pointing at that, right?
In G,
Yes.
see, because and I think we should make that clarification, that because the way it can be interpreted is that at the time of the screening, if a youth has been identified as having significant symptoms of depression, suicide ideation, that the comprehensive mental health assessment, psychosocial assessment, is interpreted as being required by a licensed clinician. And in the operationally, we utilize the licensed practitioner of healing arts definition that includes the licensed or waivered staff. So they have the education and the registration, and they work under someone else's license, and they're qualified to do the regular comprehensive assessment. But only certain individuals that may or may not be fully licensed, they may be waivered, but they have specific training to be able to put someone on a detention hold.
So my opinion, I see this separate from that initial screening. This is a separate thing. This isn't in line and doesn't come from that initial screening and assessment. This is in addition to, this is what happens within the facility. Just like in C, that therapeutic services and preventive services are provided to all youth in the facility, right? So G is everybody in the facility, and it doesn't have anything to do with that initial intake screening and subsequent assessment. This is any kid that finds themselves in crisis is going to be evaluated by a licensed staff. So, that's,
Well,
when I
and
read
again, I think I think then we need to further define crisis, because does that mean that a crisis evaluation for hospitalization consideration is different than a crisis that can be managed through engagement and safety planning.
right, so
And
that, like D and E point to that. Crisis intervention, management of acute psychiatric episodes, stabilization of persons with mental disorders, and the prevention of psychiatric deterioration in the facility. So perhaps in G, we need to spell out any youth display significant symptoms, severe depression, blah, 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 provide a mental status assessment by a licensed behavioral mental health clinician, psychologist, or psychiatrist that may lead to a psychiatric hold outside of the detention facility. Something like that.
yeah, and I would still take out by a license and to be replaced by qualified, meaning like a licensed practitioner of the healing arts, because our county utilizes associates, and not every county is going have licensed people only doing their detention holds.
So do you, in your county, do you have non-licensed staff certified to do 5150 holds?
Because they're considered LPHAs.
Mm-hmm.
They're licensed practitioners of the healing arts, and they have all the same rights and responsibilities as a licensed provider. They just work under they're receiving supervision. They're receiving clinical supervision.
So how
Whereas
are they certified to do that? How are they certified to provide that level of intervention?
through training and through certification through the county. I can double check to see if all of our crisis
Yeah, I
staff.
would be hesitant to
I mean,
take out
because it might be, but I think just I'll find out about that today.
Yeah, I'd be hesitant to take out the specific licensure of and the, level of training for someone that so because what you're talking about, a detention hold is different than a 5150, where we're going to ask that that kid be evaluated for hospitalization. We're going to send them out.
Right.
We're going to put them on a hold and send them out and ask that a higher level of care be investigated.
Right. So when I mean a detention hold, I mean 5585, 5150. I don't mean, we don't put them on a hold within the facility. Now, the transporting folks might put them, like if they're utilizing the sheriff's department to transport them, and they're using the ambulance to transport them, they might be on a 1799 at that particular point, but my staff don't do that. And so I think it's just there's an interpretation, at least in our facility, that the mental status assessment for somebody who has the high MACI, it must be done by a licensed staff. And we utilize LPHAs, right? And that's different for the comprehensive psychosocial assessment. But what we're talking about in G, and again, the need to clarify the language and really what the intent is. And I think we're pretty clear that G is related to someone who may need a psychiatric inpatient evaluation.
I think we should add that at the end of this section. Assurance that any youth who displays significant symptoms of severe depression, suicidal ideation, irrational, violent, self-destructive behavior shall be provided a mental status assessment by a licensed behavioral or mental health clinician, psychologist, or psychiatrist that may result in inpatient psychiatric care or at an inpatient psychiatric facility.
Because I think that's important if that's the intent of that, to be very clear.
I
That-
think that clarifies it.
That G is specifically for those youth who are actively suicidal or gravely disabled.
Yep.
Who need essentially a higher level of care. They need
That's
an inpatient consideration.
Right.
Yeah.
And I think that's the way I've always read that section.
No, and I think it makes the clarification that that is what that mental status assessment is designed to do.
Mhm. Did we conclude C? Is everyone comfortable with what was added to C and what was subtracted from C?
I don't like the broadness of the current youth population. Weren't we kind of talking really about individualized needs?
I thought I heard language of in accordance with the needs identified in the assessment. Was that?
In the
that correct?
psychosocial assessment? Yeah.
Yeah, I was the one that said in according to the needs of the current youth population because again, my thought was that this is a menu of services that are provided. But that, I mean, I think to make it clearer according to the needs identified in assessments, I think saying the assessment makes it confusing to me because you want to tie those services to what assessments have revealed to be required. If that makes sense.
But if we're talking about a psychosocial assessment, that is the mental health assessment,
Right.
not just the larger.
Or
Oh,
the
sure.
assessment process.
If it's much more important that it works in the facility. So I just, yeah. Or the assessment process. It's like reading my mind.
Would it help to say, because above assessment by behavioral health program when indicated by screening process or health assessment, according to the needs identified in the assessment process conducted by a behavioral or mental health provider?
And do we need at any point to indicate that an assessment in this context of B is a psychosocial assessment and mental health services are voluntary? So and this is why I think adding the evaluation language, like the mental status exam and mental status evaluation, is important because it allows us to know that the youth's emergent needs are being addressed irregardless of their participation in voluntary mental health services. Because it's just going back and forth with the court a little bit about some of the language and terminology to try to get some standardization. And a lot of their concerns were about a youth's immediate safety. They're upset in court right? They want BHS to evaluate them. And really what they're trying to get at is that they're being evaluated for emergent needs right now. And we, for emergency purposes, don't need consent for ongoing treatment per se, because we're only evaluating for safety and higher level of care needs. I mean, does it make sense? Am I overcomplicating it by adding this additional language? I mean, because it makes sense in my brain, but that doesn't necessarily mean it makes sense for everybody else.
We can pop it on screen if you want to see what it looks like. There's language that you have.
To me, it would replace B, or not replace it. It would put B and C. So there would be a new B, if you will. And let's see if I can articulate this. I get operationally, let's just play around with this a little bit. So operationally is the youth will receive an evaluation, which again is in my estimation, a mental status evaluation. To identify, because it's different, and this is where I think we might have to change that mental status language in G to crisis assessment. Because to me, youth will receive a mental status evaluation to identify urgent mental health needs identified in the assessment. Identified in the screening. Because then to me, that kind of takes away some of the concerns that people have that the screening wasn't done by a mental, and we can play with the language in that. But to me, it takes away some of the concerns that folks have about detention staff doing the screening, because we know that as a result of the screening, everyone is going to get an evaluation. Youth will receive a mental status evaluation to whether it's triage or identify urgent mental health needs. Does that make sense? I mean, Meredith, so as a non-mental health person, I'm talking about in the logic and the flow of it. There's a screening, and then there's a mental health provider doing an evaluation. Are you safe? Are you good? Even if there's not identified urgent, and we can take that part out, but every kid's getting a mental status evaluation. Are you okay? Are you good? And then we get to the offer of voluntary mental health services, and then we do the assessment. I mean, so does that assuage any concerns that you would have about it being left, the identification of needs in that very early period, not being solely at the purview and discretion of a screening tool administered by detention staff?
As a non-mental health professional, I'm doing my best to keep up. This does sound like it's a little more aligned with what I'm seeing in the national standards, but I'm let me see if I can state back what I think I'm hearing. So there's the intake screening with a tool. everybody gets that. And that happens at intake, like almost side by side with all the other, are you safe to come into this facility kind of questioning. Then this new B is again, everybody, is that what you're saying? Everybody gets a mental status evaluation. And this is like and you have a screening when we have evaluation and assessment. And this evaluation is just aimed at urgent needs. Is that?
Well, it's so the timeframes in our facility are kind of set by the results of the screening. Again, high score, low score.
Right.
Then we're going pretty much immediately high score. We're going to pretty much immediately go meet you and address any of your mental health needs. And then we schedule the comprehensive psychosocial assessment if you don't already have one, because many of the kids do, right? Because they've been here, they were just here last month or 6 months ago, and it's still valid. We do check in and see if there's a need to update. If something significant had happened, we also utilize the CANs and some of those identification of needs and strengths tools. But yeah, I mean, so it doesn't have to, it's not solely about urgent conditions, but it does capture urgent conditions.
I would think if we're gonna put this into the minimum standard, because like in our facility, not every kid is provided an initial screening, and it's semantics here, Amanda. It's the same thing as what you're talking about, but here with our mental health staff, it's called an initial screening, and that typically will come from and be informed by the intake process. So if there's any positive responses to any of the intake questions, then there's an initial screening done by a mental health staff. That may not then absolutely lead to a full-blown assessment, just depending on that initial screening that they do. But I feel like if, the way that this reads is that now it's mandated that this mental status evaluation must be done with every kid. And if that's the intent, then we should include language that specifies within, some way, because like for us, we don't have 24-hour mental health staff. We don't even we have 6 days a week. Do you know what I mean? So there's going to be situations where a kid might come in and be here for 24 hours and then get released, and they're not going to have this. So
right. And see, that's I mean, that's part of it, and you're right, it's semantics because you're calling it an initial mental health screening.
But it's the same, it covers the same things that you're describing.
Right. And we call it an evaluation.
My concern would be making a minimum standard that mandates that every kid that walks in the door has this mental status evaluation, because I don't think it's achievable for all facilities, right?
Well, in our facility, it's always based on whether they're released or before we can evaluate them. So the Macy score is the highs. The evaluation is to occur within 24 hours. The lows are to occur within 5 days. So
of the booking date.
And so sometimes the youth, and it depends on each county, because some counties don't keep kids
right
beyond, they'll book and release, or they'll OR them versus waiting for their first court date. So it's always predicated on whether they're in the facility. For us, it's always interpreted and predicated upon whether or not they're in the facility at the time. Because if we don't have a chance to evaluate them, because let's say they came in at midnight and then they were released at 8 a.m., and that we don't have any staff on site, then they would, they don't get that. So I don't know how we operationalize the language, because it's also part of that. And I think this is where I think the offer of voluntary participation in ongoing mental health treatment, I think language is
We would need to add that to C. So that in terms of the voluntary nature of, because if a kid's in crisis, that potentially would lead to an involuntary services, right? So
Right.
C is where the language regarding the voluntary nature of their therapy would be included. That's my opinion.
Right. Because safety is safety, and
Mhm.
we're gonna
Yeah.
evaluate or assess. We're gonna evaluate that for
So
sure.
So I just want to check with Forrest, and maybe I'm being too narrow in my thinking on this, but if we include B, the new B, mental status evaluation, and like what Amanda describes in terms of the time frame, like within 24 hours, within 5 days, and you're evaluating for that, does a policy that reads that way specific to this being a mandate, would that suffice? Did my question make sense?
We were both kind of listening. I don't, I don't know if I understand the question. Are you saying, so B is intended to sort of, to elevate if a young person's in crisis and the screening process identifies that it goes to evaluation, a higher level rather than assessment.
Not exactly.
Yeah,
So
okay, sorry,
Amanda's
and
suggesting that every kid gets, in addition to the intake screening process, because every kid that walks in the door has an
Right.
intake, right?
Right.
And Amanda, I'm understanding Amanda's intention with B to be that in addition to that, every kid at intake, every kid that walks in the door has a mental status evaluation. But then I fleshed out that, you know, if they're released prior to
Right.
the ability of staff to do that, and, you know, policies state it that way, I mean,
In
in
case
terms
it's
of an
help,
evaluation, can you evaluate it that way?
I was just gonna throw in case it's helpful, that the national standard sets what I think is this, kind of similar to what you're describing, Amanda. It sets it at like no later than 7 days. So you have screening, then maybe you have an evaluation to occur within 7 days. If they're released before 7 days, then that doesn't occur. But you do still have the health assessment happening within 96 hours. And I think when I look back at the health assessment, 1432, it does have some like inquiry around the kinds of things that might indicate further behavioral or mental health assessment by a provider in that field. I don't know if that was helpful, but that would to bring it back, the newbie putting like a 7-day timeline that would allow Kristen for the releases that you're talking about. It would at least narrow it to be only when it's like slightly longer, not those immediate releases.
So mental status evaluation to identify urgent mental health needs identified in the screening process to occur within 7 days of booking or 7 days of intake.
I'm wondering, we have the word identify twice, and that's confusing me a little bit. So mental status evaluation
To address urgent mental health needs identified in the
Okay.
screening process
Yes.
to occur within 7 days. Yeah, I'm comfortable with that.
Of booking, 7 days within 7 days of booking.
Within
Or
7 days of
intake.
booking or intake, yeah.
Can I ask you, Amanda, is when you have a term like mental status evaluation, is that understood in the field to like, does that mean something specific so that you would know who is going to do it? That's, I think you were describing like,
Yeah, I think you can do mental status evaluation. The other term is mental status exam. Now, mental status exam gets a little more specific where it does require the LPHA, the is similar to what it says down at the bottom. It's kind of, again, collapses of terms. It's the regulations say doctors, nurses, counselors, therapists can do a mental status exam.
Well, and I think that's helpful, right? Because if facilities do have interns, they are qualified to do a mental status exam, but may not be qualified to do the bigger psychiatric assessment that may result in inpatient.
Right.
So I guess I asked because A and our old B both say who's supposed to do it. And so I'm wondering if we should also say that here. So mental status evaluation by. What would the blank be?
I mean, are we talking about a qualified mental health provider? But then,
I
I
think
mean, that
if you
works for me, but
Yeah, because you're not also including, the only place that licensed is included is in the more severe assessment that's happening in G, right? So I agree with Meredith. If you want for just consistency and flow, mental status evaluation conducted by behavioral mental health staff. Is that what we have? Behavioral mental health provider. Yeah, because then that's just consistent, right?
And then our old, or this B that I guess will become C now. The assessment is the more in-depth, right?
Yes.
Okay. And so I would just suggest that the national guidelines say 30 days. That to me helps like again, go back to the logic flow of like where we are. So like this is the 7 days and then this is longer. Just so that it's clear how these pieces scaffold together. I'm wondering if that makes sense.
right. And are we all, Amanda, do we have a definition of assessment in the glossary? And then do we, if not, do we, I would think that we need to explain or explain what we mean by assessment in this section. To me, when I hear assessment, I'm thinking of, again, the comprehensive psychosocial assessment that anyone would get if you go to the outpatient clinic down the street. If you show up at our county behavioral health, you're going to get the same assessment that we would do within the facility, the standard and customary.
You don't think that just by virtue that it's within the mental health services section, that the language denotes that? Because I think it does.
Yeah, I mean, if everybody, again, the non-mental health providers who want to overanalyze the language,
Because I think
think
within,
that's sufficient, then I'm okay with that. I'm just thinking about,
yeah,
again, and this might be again a good again kind of qualifier question for Forrest and Allison. When you know, do y'all know what we mean when we say assessment in this context?
I do. And I mean, I do. I'll just stop there.
Okay.
And if I could, I mean, I understand in the context, but also, let's just say, if I'm just off with how you guys were discussing it, but so with B, I get a little confused a little bit when I look at urgent, and then I look at within 7 days of intake. Because if I'm doing an inspection and I'm looking at like somebody's on some kind of mental health watch, and and I've had this, if they've been in intake for too long, I'm looking to see when have they talked to behavioral health? Like, when have behavioral health been there? In 7 days, it would be a problem for me if it took 7 days for somebody to come and do some kind of evaluation and assessment.
Right.
But
That
if
may
you
be just-
consider it this way, Forrest, if you have a situation where you don't have mental health staff on site, like on the weekends, for instance, right? And let's pretend Monday's a holiday. So right there's 3 days. So that's why I'm saying like it to,
So one thing that maybe could be added or somehow put in there, usually what we'll see, and you guys probably have the same, is if you have something urgent like that, there's a 24/7 on-call mental health provider where you can call, a county
call for
agency or whatnot.
advice.
Yeah,
Mhm.
and get some kind of follow-up. It wouldn't be like the 7 day. So you would get some kind of and that's typical of the smaller counties too. They have that crisis hotline where they can call and get you know, whatever assistance they might need or whatever.
Right. And I think that really is a good kind of distinguisher. And I think you're right. There really has to be a distinguisher between, okay, what are the urgent needs and what is the response for that? So any urgent needs would either be addressed through your after hours emergency protocols, right? And non-urgent needs for mental status evaluation could happen up to 7 days, again depending on it, because this is all needs driven.
Right. And at the same time as well, that 7 days can be mixed in there, but also in the beginning, it says the facility administrator and behavioral health and health service shall together make, a policy. And a lot of times the facility policy is going to be much sooner than that 7 days. So we want to make sure, leave some flexibility for the agency policy to dictate some of those timelines. I know we have the national guidelines and stuff, but I guess you would say no more, that doesn't exceed the national guidelines or something to that fact. But like I said, they have their own policies and procedures, so it'd be good to kind of leave some flexibility in the wording that allows that.
Well, and I also it's almost like um the the addressing of urgent needs should be done, like I said, within like 24 hours or something, right? And then no other non-urgent or emergent, I don't know the right word for it, should happen no later, within 7 days. Kristen, does that make a little more sense? Does that kind of address what Forrest is talking about?
Yeah, I think the more clear we can be with it, just specifically because of the inspection process. Yeah, can you add that language, Amanda, so that we can see, just kind of read it all together?
I'm sorry, where?
I think it was in the new B, right?
Yeah. In the new B, to say that urgent mental health needs identified within the screening process to occur within 24 hours.
Mental status evaluation conducted by behavioral mental health provider to address urgent mental health needs identified in the screening process to occur within 24 hours of intake.
So are we
And
trying to
and
say
then
that the screening needs to happen within 24 hours or that the needs, just the grammar on the sentence is throwing me off a bit.
Yeah.
The screening need to be done in 24 hours, or the mental
No.
status evaluation need to be done within 24 hours?
Yes,
or
the
within
mental
24
status evaluation to be conducted within 24 hours for urgent needs. And then I think there should be,
Still sounds
do we,
weird.
do we want to say anything? I mean, are we talking about like low to moderate needs? Are we just talking about all other identified needs to be evaluated within 7 days?
Mental status
Mm.
evaluation conducted within 24 hours of intake by behavioral or mental health provider to address urgent mental health needs identified in the screening process.
Can I
Intake.
just
Sure.
sorry, Kristen, I just want to clarify, this is every youth, the intent is that every youth gets the mental status evaluation, correct? Not just a young person that has urgent needs.
Right, and what we're trying to do is make some kind of timeframes and some expectations that we capture the urgent needs that we
So then, I'm sorry to interrupt,
go
Amanda,
ahead.
but we're
Go
going
ahead.
down a rabbit hole here, and I wonder if so mental status evaluation. Can we just for right now take out conducted within 24 hours? So mental status evaluation by behavioral or mental health provider to occur within 7 days. To occur within 7 days of intake, period. And then for this part, if urgent mental health needs are identified in the screening process, this will be addressed within 24 hours of intake. And I think if we leave it open like that, that allows facilities to take into consideration their community supports that they have, whether they have a crisis stabilization unit, and then they can spell out what happens if mental health, like what we do in our policies, in a situation like this, if mental health is on site, this is what happens. If mental health is not on site, this is what happens, right? Because I think that way we're addressing both. Every kid's going to get the mental status evaluation regardless within 7 days of intake, which I feel like is what Amanda was saying was important. And then in addition to that, if there's urgent mental health needs identified during the screening process, that will be addressed within 24 hours.
That
Those
makes sense to me.
needs-
I was gonna ask Kristen, what do you think about putting that sentence, attaching it to A, which is where the screening is happening? If I'm following you.
Yeah, I think that would be fine. If urgent mental health needs are identified, it will be addressed within 24 hours.
What is it? Are you providing
If
a
urgent
service
mental
or are
health
you
needs
giving a
are
referral?
identified in the screening process, they will be
For
will be
any
addressed.
urgent mental health needs identified in the screening process will be addressed within 24 hours. Is that
will be
correct?
addressed within 24 hours. Urgent mental health needs identified in the screening process will be addressed within 24 hours. And then I don't think we need to spell out how they're addressed, right? This is the guide, and facilities need to determine within the resources that they have in their communities how those will be addressed.
This looks good to me. I wanted to ask for our new C. Can we say, so assessments when indicated by screening, health assessment. Now I would also add for the mental status evaluation to occur within 30 days. I'll just test to see if I'm understanding it right. So now we kind of have like 3 different places that could sort of indicate that a full assessment is needed. Setting aside that there are some things like Forrest was raising that I think we addressed the more urgent. Testing to see if I'm understanding. Does that make sense? Is the way I'm
Mhm.
describing it?
Mental status evaluation, then an assessment when indicated by the screening process, mental health evaluation or health assessment within 30 days of intake. Yes. And then I think in the therapeutic services and preventive services, according to the needs identified in the assessment process conducted by a behavioral health mental health provider. So I think maybe we say voluntary, therapeutic, and preventive services.
Well, we even consider the assessment to be voluntary. So the screening and the mental status evaluation,
You're right, because a kid has to sign
they have to
the
consent,
consent to participate. That's right.
right?
So
So
maybe voluntary assessment and then voluntary therapeutic and
right.
preventive services. Because we can't force them to participate, right?
So it certainly will be offered, voluntary. Yeah. So I think we have to say that voluntary assessment and services,
Well, that's in the next one, voluntary
right.
therapeutic services and preventive services. Spelled out there.
And do we want to say in the new C, that the assessment has to be completed within 30 days of acceptance of voluntary services? Because let's just say the youth come in and we've identified and at their mental status evaluation that there's an indication that there are some services, but they say no, and then a month later then they were like, I need services now. So at what point does that clock start of the 30 days, if they did not agree to them at the first time they were offered? Because they can change their mind tomorrow. That's not a problem. We'll put them in the queue. But I just, for the language purposes,
Yeah, I agree with that. Within 30 days of
acceptance of
acceptance
services.
of services
Volun-
being offered.
I would even say that assessment by a behavioral health clinician, within 30 days of acceptance of voluntary mental health services, something like that, and put the voluntary at the end.
Sorry, you said within 30 days of acceptance
Of voluntary mental health services.
So are we talking, am I typing this in the wrong place
No,
then?
no, you're typing it in the right place. What I'm suggesting is the
Because
voluntary.
the assessment will lead to the creation of the treatment plan for the therapeutic services.
But then shouldn't it be in D? I'm confused like Amanda, because how will they know what the services are until they've been assessed? Isn't it C that would sort of be the deeper assessment that would lead to
Mhm.
a
There you go, that
plan?
captures it.
Yeah,
Okay.
that was what I was saying.
Mental health evaluation, health assessment within 30 days. No, that doesn't,
Well-
not, because they're not receiving a voluntary assessment within, we're defining what that 30-day period is right now. For health assessment within 30 days of
Acceptance
acceptance.
of services.
Acceptance of this offer of services,
Yes.
acceptance of the offer of services, accepting the offer of services.
Yeah. Amanda, you have an or.
The offer of services,
Yeah.
not or, yeah.
So we're saying that the voluntary assessment performed by this person within 30 days of a youth accepting services that they haven't been assessed to receive yet?
Accepting the offer of services, because they're going in to assess them. They're offering services and saying, we're going to do this assessment that's going to lead to services. Do you want to participate?
Okay.
And I think we're just making it extra clear in D, voluntary therapeutic services and preventive services, because we can't mandate that they participate, right? Voluntary.
No, because this delineates that behavioral health services are not programming.
Right.
Because programming is more mandatory. There can be therapeutic services that are part of the programming, but not in the way
Right.
that this is defined in mental health for treatment.
Right. And the reason we need to spell it out this way is because some of this is not voluntary, right? Crisis intervention is not voluntary. The kids in crisis, then staff are going in to help alleviate that crisis.
Mm-hmm.
Maybe I just need a break because I'm still sitting confused with this. Maybe I just need to read it on my own because to me it's
Well, it
still
is almost
sounds-
lunchtime and we've been powering through, so.
Okay.
I think I'm still stuck on the same place as Amanda F, in the sense of just, this is a question. Okay, I want to decide whether I want to go through assessment under C. I guess as a teenager, I'm wondering, would I understand this offer? Basically, we want to offer you an assessment that you should only accept if you want services. I feel like as a teenager, I wouldn't really know what like mental health services means
So let me
without
give
more
you,
specificity. And you won't be able to be specific until you've had an assessment. Amanda F,
Well-
is that kind of similar to where you're getting stuck?
I am. I honestly just think I need a break too.
The last thing that I would add to this is, I broken record Allison over here. The policy, this is the regulation that requires the agency to do these things. The agency is going to have to be very careful in their policies to make sure that it's clear to the young person. So, like, I don't want to get, because I think I'm along the lines of Amanda F too, like I'm blurring a little bit. But if the requirement is that within 30 days of an offer of services from B, that a voluntary assessment is done, it's the responsibility of the agency to have that clearly outlined in policy and procedure. And I don't know if that helps, Meredith, because the kid isn't going to go to Title 15 to understand. They're going to be they're going to be informed by the agency policies and procedures.
Right.
and what I can say, like specific to your question, Meredith, like I just happen to have a chart here on my desk and I pulled out the consent that the kid signs to voluntary, to participate in services. And it spells out, it's 1 through 5, right? And it starts out with mental health services may include assessment, crisis and medication support services, or other mental health services. And then it goes through and delineates out like the frequency could be, you have the right to accept or refuse at any time. So it spells out and what the kid is agreeing to and defines what the services may include, including assessment.
Okay, that's great. That makes sense to me.
Yeah, and I think most programs are going to have something similar.
Right, because it is all part of our ethical responsibility
Right.
to provide informed consent and
Right.
to explain, as Kristen noted, and it's often very it's literally spelled out
Mhm.
very specifically on the consent for treatment.
Mhm.
And then operationally, again, we have the obligation to explain what that is, what services we provide here, how they might benefit from that. whether that's with emotional regulation, adjusting to the detention, and then that's where it gets in a little bit more of oftentimes okay, you've indicated that you have concerns about X, Y, and Z, and in your screening or in your evaluation, and we can help with that. So again, that's where the conversational part comes in.
That makes sense to me. And that happens before then they're getting a full assessment. Okay.
Yeah, all the consents are established upfront. Where with the option of designating or declining to exchange information with their parents, with the court, with the other entities, the health clinic, this education, and as part of, again, our standard customary package of release, consent and release documents, of which then they can change their mind at any point.
And they do.
And then
Should
they
we,
change it again.
should we break for lunch?
I think so.
Yes.
Okay. Okay, thank you so much, and we'll converse amongst ourselves and reread this and join back up at 1 p.m. Thank you, everybody.
Okay.
Hey, Meredith, before we go back live, I just wanted to say that I appreciated you and Joni's perspective about, when we talked about consent to release information, and, and that whole conversation that we had last time or a couple of times ago. It really helped me kind of reshape my thinking a little bit about certainly my my concern about really that confidential nature of that protected health information that we're talking about in the assessment particularly. So I've just reframed my thinking about it. I've reframed how I speak to the court. So I just wanted to say thank you.
Thank you for saying that. I really appreciate the chance to collaborate and learn from all of you. This is all, bringing together lots of areas that I've had some exposure to, but not the depth that you all have. So thank you for the opportunity to learn as well.
Yeah, I mean, we do what we do, and until we get some additional information that
Right.
helps us, spark a whole new line of thinking, or just kind of expands it out. That's definitely, helping me expand a little bit the larger implications,
Right.
that I don't necessarily think about. And then I think that's what you're saying as well.
Yeah, totally.
In our cross system collaboration here. So
Exactly.
I didn't necessarily think that, that needed to be recorded for posterity. So although I would be fine saying it in public.
I appreciate that.
Okay, we are back. Thank you, everybody. I hope everybody had some good lunch, maybe a little bit of sunshine. For us in here, we are just about frozen, so we went outside and got some warmth. Are we moving on? Oh, wait, no, we did say we were gonna read this again. Did everybody want to take a quick look on what we came up with for 1437? See if there were any other questions and then if we can move on.
I still had some things to discuss about the, I guess it was the old G. Now the H, wait, let's see. Yeah. The licensed behavioral mental health clinician. I was able to verify that San Joaquin County Behavioral Health uses the associate registrants who've received the training along with licensed mental health clinicians who've received the training and have obtained detention privileges, the ability to write involuntary holds. So, since this is kind of related, it kind of goes back to my original question and comment about utilizing the word LPHA, the licensed practitioner of the healing arts, as a umbrella term to capture the associates and the licensed staff in that, formerly known as H.
But is that title that you're talking about, licensed practitioner of the healing arts, is that something that's specific to San Joaquin County and how they define? Because like in Sonoma County, it's behavioral health clinician or behavioral health clinician intern.
No, the Cal Mesa clinical documentation guide references LPHAs as that category to capture essentially the registrants who are have a master's degree and an associate registration number along with the license. So it is a state of California definition and not just a San Joaquin County definition. If it's not going to limit who can provide a crisis assessment, then it doesn't matter. Each county can identify it and define it the way they identify it per their standard and customary practices. But if it's not going to, so my concern is that then if the requirement is for someone to have this essentially crisis assessment done in the community by a licensed provider, but the provider allows for licensed or waivered staff, so to speak. They have a license. It's just called a they're just not fully encumbered and they require supervision.
Right, they have a number to be, because they're still working on their hours, which is why they're not considered fully licensed.
Correct.
So they're still in training, they're still being like weekly management, basically.
Yeah, they're working under somebody else's full and unencumbered license. In our systems, it's actually quite common because that we actually get quite a lot of clinical supervision in these contexts. So as long as a kid, if they show up at the from a juvenile detention facility and are seen for the crisis assessment by whomever the county has determined to be qualified, rather than them say, oh, you must, my licensing requires that you be a licensed marriage and family therapist or licensed clinical social worker. Otherwise, you see what I'm saying? If it's not going to be an issue for the facility, then it doesn't need to be changed.
I'm not sure what you mean.
So if it says by a licensed provider, I guess the associate registration by default is under the kind of auspice of a licensed practitioner of the healing arts. The detention facility won't know the difference, right? So
So I respectfully disagree. I think that if it says licensed behavioral or mental health clinician, psychologist, or psychiatrist, that means someone with a valid license to practice independently. If you have a registration number as somebody that is practicing under somebody else's license, that's very different than somebody who is licensed independently.
okay, then operationally, there's a barrier.
How?
Because if a kid went from my facility right now to the general hospital for a psychiatric mental health crisis evaluation, I can't guarantee that that person evaluating them would have a full unencumbered license. They might be,
You mean the hospital staff
no, the behavioral health staff.
within the hospital?
No, that goes from BHS to do the mental health crisis evaluation. So our licensed practitioners of healing arts, we call them clinician ones, who have an associate registration number and have been deemed by the county to be qualified through their training and their scope of practice to be able to put someone on a 5150 or 5585 hold. And they may not have a full unencumbered license. They're still qualified. They can do the mental health assessment through CalAIM. It can do all the things. It can provide therapy. They can do all the things that the fully licensed staff can. They just have the additional requirement of attending clinical supervision each week.
Can I interject just real quick?
Yes.
Just as a reminder, so part of our, I guess, our conversations and revisions with this stuff is to consider how it would be inspected to. And so, you know, the field rep just inspects to what's going on within the facility. So then perhaps some of what you're saying may be just specific to the healthcare folks, their policies and procedure, and not as intertwined with the collaboration of the facility and, you know, in the beginning it says the facility and the medical and you know, facility administrator shall create policy, ... I understand that, and the facilities can still be involved with that, but when we start getting into the regulations and things like that and what we can expect to, we don't go as far as looking into, you know, particular licenses of the outside folks. It starts getting outside of our realm of inspection, I guess you could say. Does that make sense?
Yes. So it sounds like what we're saying is for this particular language, even though it says license, that is not something that the BSCC is going to inspect to, and they're going to defer to the behavioral health administrators and the detention facility administrators to come up with policies and procedures that best suit their needs. So it sounds like we don't need to change it.
You're correct. That's what.
Okay.
Yes.
And it all, because I had that question for a long time. And since we had kind of clarified this morning, the real spirit and intention of that section really is about crisis emergency evaluate assessments that may lead to involuntary hospitalization, um, versus just internal non-crisis. So I'm fine with it.
Okay, are there any other? I think we're at the end of it now after that, right? Okay, are there any other suggested changes, additions, modifications? Nope. Alrighty then. Moving on to 1437.5, which is transferred to a treatment facility. It doesn't look like there are any suggested changes to the language. I did want to address and I guess ask a question about the SYTF subcommittee recommendation, include transfers to state hospitals. As far as I'm aware, counties don't maintain the same contracts with state hospitals like DJJ did. So that language probably wouldn't be appropriate unless there's something I'm not aware of.
I'm not sure about that either. Are you saying that if a person needed inpatient psychiatric care, they wouldn't be, because we're talking about like a Atascadero, right? We're talking about like a commitment facility?
Well, I mean, if we send someone out and they require a hold at a psychiatric facility, they're gonna go to, you know,
Look,
Santa Rosa Behavioral Health,
got
Alta
it.
Bates.
I
You
see
know,
what you're
there's
saying.
the Center for Psychiatric Care in Sacramento. So there's
I s-
hospitals that they would go to, but they're not necessarily like the state hospitals where I know DJJ used to send kids and they'd sometimes stay for extended periods of time based on contracts that the state maintained.
That makes sense to me. And that's, so that's
Like we
not, it's
wouldn't,
not going to be a thing because
right?
the relationship with the county, for the county to get the kid inpatient treatment would be the local, whatever the local system is, not.
Well, and wherever they're accepted based on, you know, the assessment that's done either through the crisis stabilization unit in each community or at the emergency department in the community, wherever they're presented to and accepted at, and it's not going to be a state hospital.
That makes sense to me, and we'll make a note of that to bring that back to the SYTF committee unless there's other comments. That makes perfect sense to me, and hoping, just checking to see if it makes sense to others.
Right. For me, it also makes sense that the state hospital is a whole different level. It's a commitment, right?
Yeah,
They're like,
exactly.
they're gonna commit someone to a Tascadero, for instance, because outside of just a there are no youth mental health state hospital beds anymore.
Right.
So this is, to me, purely reads as those episodic short-term involuntary stays with the intention of stabilization, and when they are released from that level of care, then they come back to the facility. So yeah, state hospitals outside of the realm.
Yeah. So anything else that anybody wants to consider in this section?
I didn't see it anywhere else, but I thought there should be a notice provision on a transfer for that the policy should include notifying the parents and the attorney. And I was going back to look in our, like in the death and serious injury, it doesn't look like that covers this necessarily.
Well, On my
It's a-
origin, okay, go ahead. Because I was gonna say on my original binder, it had a BSCC suggestion to add required notification of youth parent, guardian, and attorney upon transfer.
Would that
And with
only
a question.
Would that only be applicable to minors too, if there were an SYTF youth or older youth and they were 20? So if that goes in there, should it be,
Well, I think typically whenever a person who is detained in a facility is transferred to another facility, there's notification that goes to the court and everybody because they're outside the facility, right? They're like, in this case, they're being maintained outside the facility without custody staff with them. So there would have to be notifications that legally go to everyone. Like, we have a policy that spells that out, like how notifications happen, because from a legal place, it has to. Court has to be notified, and then therefore all the attorneys involved and the parents, so. I don't know that that's necessarily the responsibility of the health services staff. We have it so that our staff inform probation staff who then make the notifications. So I'm just pointing it out. I don't know that it lives in this section necessarily because it's a bigger issue than that.
I agree. I don't think that obligation would fall on health services staff, but I don't think that these policies and procedures are limited to things that would be carried out by those staff. And
I'm just wondering, is there somewhere else in the
Yeah.
regulation that it discusses if detained youth are transferred to another facility or another treatment facility? Is there a general statement somewhere else that addresses that? How and who is notified?
one doesn't come to mind.
the only thing I could think of was like death or serious illness or injury. You get notified of that. But that's not, like you said, that's not transfer. So I didn't see anywhere else that it would be covered unless that's 1341, unless that was edited to include transfers.
Because this is
1351 is more, 1351 is more about the general release procedures. It doesn't say specifically transfer, but it does speak of the different processes and the notifications to the parent or guardian, notification to the facility healthcare provider in accordance with section 1408 and 1437 of these regulations for coordination with outside agencies.
well, and Forrest, is this because this is considered a temporary transfer? Does that make a difference? Not in the notification process, like people don't deserve to know, right? But is it considered the same as a transfer? So like, it's one thing to transfer a kid to Sonoma County because he's awaiting, disposition or charges there, versus a transfer to this Aurora hospital in Santa Rosa for the temporary purposes of stabilization, just like it would be a transfer to the general hospital if somebody had a physical injury. For physical injuries, and they take them to the emergency room, parents, I believe, get notified.
Yeah, they get notified by the JC or probation staff.
Mm-hmm. Mm-hmm. And who's getting, because they're the ones usually are who are arranging the transport, and they're the ones who check them out of the detention facility and do what they do to transfer them or take them to, even if they just turn around and get released right back. So, Kristen, do the parents, and Forrest, do the parents get notified if a kid gets again goes to the emergency room for any particular reason?
They're
Uh,
supposed to. They're supposed to be notified by the probation staff. And
So
the
then-
way I've always understood it, at least in our facility, is it's a security measure, right? The security staff, probation security staff notify parents. And then, provide information specific to, here's the hospital, our staff are there, you can go under these circumstances, you know what I mean? But that's just like when we arrange transportation for a kid out of the facility. If I advocate for a parent to be present at that appointment, I have to get probation permission for that because of the security around it, right? But like when we transfer a kid to a psych facility to receive that higher level of care, proceedings are suspended by our court. So the kid goes, gets treatment, but then comes back here when treatment is over. So they suspend proceedings so that they can go without probation staff, without the need for further supervision at that, during that period of time.
and so I think one of the distinctions is that they may not discharge them from the facility, do a transfer if it's just to the emergency room for the evaluation, because we don't have in-house people who evaluate. They go to the general hospital for their crisis evaluation. And then if it's determined that they need to go to inpatient, and again, I don't know if they're required to again suspend proceedings so that they can go without probation guards, so to speak. So again, I'm not trying to convolute the process, because it may just be appropriate for us to put in some section, because what we're saying is there's no other sections saying that the parents get notified of transfers.
But
I have a question. Where it says treatment facility, is that a really broad term, or is that, I guess the question, because it sounds like, Kristen, you're saying that the kind of transfer you're talking about wouldn't happen without court process, in which case the attorney and parent already know. But I'm wondering if there are things that fall in the category of treatment facility that wouldn't follow court process, like they're more
Well,
emergency.
keep in mind that this is 1437.5. So this is really specific to the mental health treatment that might be required if a kid is sent out of the facility specifically for a higher level of care of mental health treatment. So this is only addressing youth who appear to be a danger to themselves or others, or to be gravely disabled. That's a 5150. So that's a kid that's going to be put on a hold and go to a psychiatric facility for specific psychiatric mental health treatment, right? So that's what this transfer to a treatment facility, that's what this is addressing.
I know that A says that, but I don't see that in the first line. It just says a treatment facility. So I guess what I'm asking is, like, I understand that it's, 0.5, so maybe it's, thought of as somehow being related to 1437.
But it
I-
calls out, and then B calls out timely referral, admission to a licensed mental health facility, and follow-up for youth whose psychiatric needs exceed the treatment capability of the facility. So that's how I've always read this, is that this is really specific to the mental health services and the provision of services outside the facility if that's what's deemed necessary.
I
So
mean,
I'm
if it,
fine.
I mean, if anything, you could add psychiatric treatment facility, because that's really what we're talking about.
That's what we're talking about. That's what
Is
the,
it, I
the
guess
purpose
that's what I'm
is.
asking is, and maybe this is a question, like a more broad question to BSCC staff. Are there treatment facilities encompassed within this other than psychiatric treatment facilities?
I think it would be psychiatric, yeah, as Kristen said, the 5150, that's pretty typical of each county. You know, if they had a situation, they would send their kids to the psych, for psych eval at a psychiatric treatment facility is, that's the most common. I don't think I've heard of.
And that never happens without prior notice to the court?
Well, it's always been my experience that if a youth is outside the detention facility for a prolonged period of time, our court has to be notified. The judge has to be notified because we're not in charge of that. Like that kid is out of our custody.
But this
You know what I
doesn't say
mean? So the court-
prolonged period of time. So what I'm getting at is like an emergency moving of a youth to a treatment facility. The parents and the lawyer should know about that in a timely way.
Yeah, yeah, that's true, but also there are safety concerns. So even when, whether it's the psychiatric evaluation or the hospital, sometime the facility will wait till the youth returns um, from like just say the emergency room or something before they notify the parent, because you put staff in danger sometime because the whole family and different visitors may converge on a certain location. So it's a little bit more to it in terms of the safety parts of it. So yes, the parent needs to be notified, but if you put it too specific, I think the facilities need a little bit of flexibility in when to make those notifications for the safety of the staff.
So can it say, I mean, these again are, the facility develops the policies and procedures for provision of notice to the youth's parents, guardian and attorney of record when a youth has been transferred. Can it, to provide that flexibility, can it be in a timely manner or within 24 hours?
But
If we're consistent with the language we used in the emergency procedure section, it was procedures to notify parents or guardians, persons standing in loco parentis, this youth attorney of record as soon as practicable. And I think in emergency procedures it says as soon as practicable in the event of an emergency. Here we could say as soon as practical in the event of a transfer to a treatment facility if we want to be more specific. I can type it on the screen.
That sounds good, thank you.
yeah, see in my, so I have a hospitalization policy that addresses both sides of it, whether it's a medical hospitalization or a psychiatric hospitalization, and we address notification to the court. So we're notifying the court that we're sending a kid and that they're being hospitalized, whether it's overnight, you know, a week or whatever it is. As soon as we know that that kid is going out of the facility and the intent is that they're going to stay in another facility, at least overnight, we're notifying the court. So for all of the reasons that we just talked about, security, you know, who's allowed to be where, all of that kind of stuff. That's not up to health services staff. Our role is to make sure that the youth is getting to the place that they can get the treatment that they need, right?
This is not requiring health services staff to do any of this. This is just policies and procedures for the facility. If it's more comfortable to put it into 1341, I think it's fine to put it there because that's notification. Or Amanda, I'm not sure where you pulled the emergency or if that's a different section, but
Oh, 1327. I was just looking back at emergency procedures that we worked on.
I think it's okay here. And I think it would be fine in policy and procedure for it to be probation's role. I think it makes more sense here than putting it over in another section. Or maybe, I mean, maybe to even make it more clear, healthcare staff shall notify probation so that so parents and guardians can be notified. If that feels or sounds better. Because I understand the sentiment, especially for a minor.
I think that's totally fine if you want to specify that it's
Does,
provisions for supervision staff. to
does
be-
that,
to
oh,
notify.
sorry, Meredith, I was just gonna check with Kristen if it makes sense to have it begin, healthcare staff shall notify probation staff in order for there to be notification, probation staff of transfer,
I think of the need to transfer.
of the need to transfer so that there can be, no, that doesn't sound right.
I think that's getting a little bit too much.
Yeah,
with the
100%.
provision.
Yeah, 100%. Give me 1 second. Healthcare staff shall notify probation staff of the need to transfer, semicolon. Probation staff shall notify. And that's okay. So healthcare procedures would look like, say it's the psychiatrist who would do it. The responsible psychiatrist shall notify the youth's probation officer, who shall then notify the parent or guardian. I think that works. And again, just checking in with Kristen and Amanda, why?
I think operationally, that's how it works.
Yep.
Certainly for us. You know, detention staff are often, aware of urgent evaluations, crisis situations within the facility. So they're the ones who arrange transport. So
Yeah.
Mhm.
And it could-
they're notified kind of immediately,
Right.
and aware of the situation. So yeah, I think
And-
operationally that works.
Okay, perfect. Yeah, because it could also be it could also be their probation officer, who should probably get notified anyway, so. Does that take care of that concern, Meredith?
Yep, thank you.
Okay.
Are we ready
1438?
to move on?
I think so.
Okay. Moving right along, look at us. 1438, pharmaceutical management. Let's see. Written policy. Resistant cardiac shall develop in a written policy. This closets and refrigerator units. Administering and delivering medication as prescribed. It looks like we're just cleaning up the language a little bit in here. I'm
And
just
this
curious, why was the decision made to change medications to drugs?
The term defined in the definitions, sorry, someone's unmuted.
Are you unmuted? I'm not.
Sorry, test, test.
Is it?
Oh, so it's only, that change is only specific to legend by way of, because of the
Drug and
definition?
drugs is defined in
Oh, okay,
1302.
got it. Okay, does anyone have any?
Sorry about that, y'all. If I was if I was repeating myself earlier, if I was echoing,
That's
apologies.
okay. Are there any other observations or questions about this section?
I did have a question. I know that in the first aid section, we added, I think I forget the generic term for like Narcan. And I was wondering if that, like in terms of storage or whatever, needed to be addressed here or not. I can't remember the text exactly that we added, but I think we added an expectation that that would be on site. And so I wondered if that falls under this section in terms of storage or management.
I don't
Oh,
think
the
so,
opioid
because
and
this is
others.
calling out just how medications and drugs in general within the facility will be managed, and it's not calling out any specific names of them. It's separating legend from, which are, the controlled versus, all medications. But that would fall under just by virtue of it being a medication within the facility, right? And then each facility has their own policies around where in the facility it will be. Does that make sense?
Yeah, thank you.
Yeah, because there's like in our pharmacy room, there's really specific ways that things have to be stored, right? Like legend drugs have to be stored in a certain way. Our immunizations have to be stored in a certain way. We have to check temperatures, you know what I mean? So so any other suggestions in this section, or should we accept and move on? Okay. 1439 psychotropic medications. I don't think there were any specific changes to this section. Does anyone have any areas to discuss or specific recommendations for this section? No? Okay. So section 1452, collection of forensic evidence. I noted one thing here in the addition. I'm pretty sure you meant in the last part of it, processes and their rights to provide or refuse consent and not for.
Yeah, that we'll fix that. So it should be their rights to refuse consent.
Yeah. Anything else there? Okay. Section 1453, sexual assaults. Meredith, did you have something about this one?
Yes, I'm looking at the NCCHC guidelines. They provide a bit more detail. And knowing some of the reports and lawsuits coming out in the last several years, it does seem to me that this requires some more specificity. Starting with the fact that this is a very reactive standard. It doesn't have anything around detection or prevention. So that is one of the aspects that I see in the NCCHC standards. So just to get very specific, at the end of the section, I would add language that says policies and procedures for responding to sexual assaults shall be in compliance with the Prison Rape Elimination Act and additionally include the following. And the first one I would add is protocols for the detection, prevention, and reduction of sexual abuse.
Sorry, I lost you after shall be in compliance with.
The Prison Rape Elimination Act.
So I can see what, Meredith, what you're getting at there. And in section 1329, and again, I'm looking at the current regulation. I don't have in front of me what the ESC worked on. There is a requirement in the policy and procedure manual section that I think, I know this is really tricky because the policy for PREA, it needs to apply to the entire facility. So in the operational section, establishment of a policy that prohibits all forms of sexual abuse, sexual assault, and sexual harassment. Policy shall include an approach to preventing, detecting, responding to such conduct and retaliation for reporting, as well as provision for reporting such conduct. I don't know that, I hear what you're saying about 1453 being a responsive regulation. I think that is the intent here, that if there is one, this is going to be the response. So I guess what I'm trying to think about is this will be the healthcare's response.
Okay,
God-
that's helpful. I'll skip
Yeah.
that part.
Okay.
Can you give me that section again, just so I can realize it was somewhere else?
Oh,
But,
sorry, you broke up. What did you ask me?
oh, sorry. I was asking if you could just give me that section again so I can
Yeah,
go
it's
find it.
section, yeah. It's section 1324, Policies and Procedures Manual,
Thank
and
you.
it's subsection N. What
So I have
don't-
more that's not specific to that, so I'll just.
Okay,
so-
and
thank you.
also, that's not, it's been a minute, so I don't have exactly the memory of what the ESC may have talked about or what another work group has talked about with respect to including some provisions of PREA in there. So that's
Okay.
the current regulation, not necessarily what's been recommended.
Okay, that's helpful. I will jump then to the standards that are more specific to response. So they recommend that health staff shall be trained on how to detect, assess, and respond to signs of sexual abuse.
I'm sorry,
And
I'm cutting out a little bit. It's going in and out
Sorry.
for me.
I'm going to turn off my video and hopefully that will help my audio.
Health staff shall be trained on detection.
Assessment. Let's see. Detecting, assessing, and responding to signs of sexual abuse. And preserving physical evidence of sexual abuse.
So I just want to interject. What you're talking about here is a very specific type of training that usually sexual assault examiners undergo. And anytime there is a suspected sexual assault, all of that should be turned over to that team. So while I totally agree that staff should be trained to, understand the implications and what their part in, helping someone through a potential sexual assault, it is inappropriate to have the staff within the facility, assessing for a sexual assault or being trained to do that within the facility. That's a very specialized thing that goes to that team to do that.
But wouldn't there need to be some in-house detection and assessment that referral needs to be made?
At the point that there is an allegation that a sexual assault has occurred, law enforcement should be called in, and that activates the sexual assault response team. So like in this county, I supervise our SART team, and they are a specially trained forensic unit that responds to sexual assault, preservation of evidence, at all. So anytime, and we have policies within our facility that if there's an allegation of sexual assault, law enforcement is notified immediately and the SART process is activated. And that's a really specialized training that is provided by the state. Like it's a whole thing. So while
I think so. What you can see in this section is it doesn't say any of that. And it's great to hear that you have that kind of a specialized team. And it seems like the training then could be exactly that we have a SART that when, at this, we immediately call law enforcement, whatever it is, any health staff could and have an encounter in which they are, receiving a report or have reason to believe a sexual assault has occurred. And so I think what the national standard is speaking to is that all health staff should be prepared to know what to do in that situation. And so that would be their training.
But by calling out that the health services staff within the facility are going to be trained to detect and assess for a potential sexual assault, I just don't think that's appropriate.
I guess it depends on what, like you're saying that those are specialized terms. So is there anything in what you described that your facility does that you think belongs here? Because again, this says nothing about how health staff are supposed to respond.
So like in our facility, if there's an allegation of a sexual assault, law enforcement is notified, and we have a facility called the Redwood Children's Center, and that's where kids are taken for an interview and an exam.
Right. So what I'm saying is like, there's not even in here a timeline. there's not even in here a requirement that, you know, law enforcement be notified immediately.
I think what I'm struggling with is that this section, I'm going to see if I can say this intelligently. This section is for how healthcare staff support youth who have been the victim of a sexual assault, which like, reactive as it is, that's different from the detection and reporting of abuse, assault, harassment, those things, which none of which are less important than the other. So my question is, if this is the section for healthcare administrators to treat, preserve it in evidence, report, ensure that they have a supportive adult, and then follow whatever procedures are related to evidence, is there
Or
a
local
different,
protocols.
I'm sorry, what?
Or local protocols, like each community is
Right.
gonna have their own local protocols about how these situations are handled.
Right. To me, that feels differently, and I don't know if we do a good enough job in another section of dealing with, I hear what you're saying also, Meredith, that every single staff member, not just healthcare staff, if there's allegation, evidence, any indication that a young person has been abused, assaulted, or harassed, all of those things need to happen as well. So I don't know if it makes sense to keep the focus on this regulation on what happens if a young person is assaulted, which is very different from if there's a suspicion, an allegation, or otherwise notice of a young person being abused, assaulted, or harassed. Does that make sense? This is very, to me, not that it's perfect, but very narrowly focused on if this happens, they're like Kristen's saying, there is an established protocol and there must be a protocol for that because it because of the nature of the event. So I guess my question is, I keep repeating myself. Is there a better place to address the detection and all of those other things? Because I also hear when you say trained personnel, that to me brings up like they have to be specially trained, but I also think about that any person working in the facility needs to be tuned in to be able to report anything related to a sexual abuse or assault or harassment. So is there a better place to put all that stuff? Under what's the header under the NCCHC sections?
It's response to sexual assault and abuse.
Not detection?
That's their header.
Okay.
Goes under specialized patient services.
So I would just say, well, Amanda, your hand is up.
Well, I was just trying to understand, this section really is for determining what the healthcare providers need to do, like in notification of notification to detention staff that an incident has recurred, or I'm just kind of talking off the top, because then the detention has their protocols of notifying the law enforcement for and SART and all those different kinds of things. So is that really how I'm interpreting this section, is really just about what healthcare providers are required to do in response to sexual assaults or reported sexual abuse? And not that the healthcare staff has to be the ones who investigate and collect the evidence. Is that how I'm reading this section? And then all of the details that we've been talking about, like Allison was saying, should go in another section. Is that?
Yeah, I think it's appropriate to say policies and procedures for responding shall be in compliance with the Prison Rape Elimination Act, which includes training for all staff within the facility. But pointing to health staff within the facility to be trained to assess and respond to someone who's alleging sexual assault wouldn't be appropriate here. I think if we wanted to say, you know, talk about training specific to reporting of such things and what to do in accordance with local regulations or local policies within the community, that's one thing, but.
Because the healthcare services staff are going to be supports to the youth and ensure that the report gets reported correctly to the right people. And then there's the whole other thing about the investigation and the notifications and such. And yeah, right now in our facility, everybody who has unescorted access participates in the pre and secure and facility security training.
Yeah, that's a mandate here
Mm-hmm.
for all
So
volunteers too.
Right. So I'm assuming that that PREA language exists somewhere else as well.
Yeah, I mean, I think it's important, and everybody, like, part of the training that our staff, all staff here receive is what happens locally if there's an allegation of sexual abuse, right? And what happens at the Redwood Children's Center, and why it's important that they go to the Redwood Children's Center, not be questioned here, but go there and have a forensic interview, and, you know, goes down that path.
So aside from training, the NCCHC guidelines recommend additional requirements, including emergency contraception shall be available to youth who have experienced sexual assault within the prior 5 days. I'll just read them quickly so you guys can get a sense of the content, and then you can see if there's anything you think makes sense. Prophylactic treatment and follow-up care for sexually transmitted infections or other communicable diseases are offered to all youth who've experienced sexual assault as appropriate. Evaluation shall be offered by a qualified mental health professional for crisis intervention, counseling, and follow-up. The facility administrator shall take appropriate steps to preserve the safety of youth who have reported a sexual assault occurring in the facility.
So all of that you just described, Meredith, is typically going to be part of the response by the sexual assault response team. So there's victim services that are put in place immediately. There's emergency contraception. There's offer of STI prophylaxis. So all of that is part of the response by the sexual assault response team in most communities. I'm familiar with our surrounding area mostly, but the immediate response goes that direction to law enforcement and then to the SART team.
Meredith, are you suggesting calling out? I hear what you're saying, Kristen. That, and because I don't have a copy of I don't have a copy of the NCCHC standards. Just looking to see what concepts you would put in there, Meredith, and if it's in there in practice, Kristen, certainly in your facility, I don't know if that's a law enforcement response or a community response that they're offered prophylaxis, emergency contraceptive, the contraception, testing, all of those things. Does it make sense to add them in a list here, or is it contained in some other standard that we could reference? Does that help with the problem, Meredith? I'm also just trying to understand, I'm,
I'm pulling up, so there's the
Okay.
California, so in California, there is a training facility, the California Clinical Medical Forensic Training Facility, who by penal code is mandated to provide training for all sexual assault examiners in the state of California. There's a California medical protocol for the treatment of sexual assault and abuse for both adult and adolescents and pediatrics. And I'm pretty sure it spells out, so I can pull it up.
yeah, or can you give me the reference too? That'd be
Yeah.
helpful. Thank you. Maybe we can even cross-reference. Maybe that will address Meredith's concern.
Yeah, I guess my question is like, so the SART, they're located where? External to the facility? Is that, am I understanding that
Yeah, it's
correctly?
law enforcement
Yes.
response, coordinated with healthcare. Sorry, I'm speaking for Kristen.
Yeah, so in every community, some SART teams are located in the hospitals. They're located like in a community hospital, but they're completely separate from facilities, and it's a coordinated response. Like here in Sonoma County, we have an MDT that our teams cross-train. They respond to both pediatric and adult sexual assaults, but the way that they're trained and the protocol that they're responsible to is the California medical protocol that the California Clinical Forensic Medical Training Center trains them to per penal code. It's written into penal code, the type of assessment, the type of forensic, how these exams are to be conducted. Most communities like Sonoma County have nationally accredited child advocacy centers that interview kids 18 and under, go to the CAC to be interviewed. And there's a lot of regulation around how they're handled, right? So they don't even want law enforcement in the community interviewing kids. They want it all to happen at the CAC. And then the exam happens there too. So let me see if I can pull up. And then there's really specific state forms that are evidentiary forms that are completed and become part of evidence in the case. It's all very regimented. Oh, let me see, where's the...
So I found the penal code on the requirement for SART. And then, whoopsie.
Okay, so the protocol.
And my intent here is, again, not to make not important things in regulation, but what I keep hearing is that the laws and responses for sexual assault
Yeah, I
would
wanted
be
to...
no different than if it happened in the community, and they
That's
would
right.
have all of those same, I think it's in the 680 section. Is that right, Kristen? Am I in
For 680 section of what?
penal code?
I think it's 1398. And so I just found the section. Let me answer that in a
Okay.
second, Allison. I just found it's prophylaxis against sexually transmitted disease. It's within the California medical protocol for both pediatric and it's on page 96.
So my ask to Meredith is if we could perhaps cross-reference those sections so that the agency already, I guess this is a case of the agency is already beholden to whatever penal code is in place, but just cross-referencing so that there's an assurance that policy and procedure will be to do that, those next steps.
I think that sounds good. I'm wondering if there's a time framework. Kristen, it sounds like you all have a policy of immediately. I don't see any kind of urgency in this section. So I would encourage us
What do
to
you
consider
mean?
something in terms of response. You know, we had, you know, response within 24 hours if there's a mental health crisis, but there's nothing here in terms of timing.
Do you mean in the reporting of it? The reporting of a crime potentially have occurred?
Right.
Well, are you saying, so reporting such incidents to local law enforcement immediately? Is that the recommendation, or adding a time period there?
Yes.
I have absolutely no problem with that, but it leaves me speechless that we would even have to say that. I just want to throw that out there.
Sadly, I have worked with clients in which there was no response whatsoever within the facility.
That's crazy. The penal code section that discusses the evidentiary exam, Allison, is 13.823. That's where it starts, I believe. And then there's multiple like subsections from there. Yeah.
I think I go back to the like if there's a law in place and the regulation repeats it and the agency still breaks the law, then they're still gonna break the law. I know that doesn't feel good for me to continue to say, but especially with reporting reporting of crimes, I mean, especially this one, I'm struggling with that. I like a cross-reference better than, but I'm gonna look up that section. 138.13823.
I just sent you the California Medical Protocol too, Allison, for how it's spelled out, for how exams are conducted, how medical personnel are trained across the state. Because that isn't unique to any jurisdiction, that's statewide. And the expectations around like evidence collection, how it's maintained, all of that is standardized.
Okay, so I'm not quite sure where we're at, and I don't have that information yet. If there's comfort in the cross-reference, if there's consensus on adding immediate response, can we just hear what our next step actually is? Like, there's a couple.
So I wonder if we can capture, so in the first section where you put such incidents reporting to local office immediately. And then in the next section that starts, the evidentiary examination and initial treatment of victims of sexual assault shall be conducted at a health facility that is separate from blah, blah, blah. Maybe we add something there that all facility staff will be trained on the local protocols, the local response protocols
I like that.
to sexual assault. You know what I mean? Like something that points
Yeah.
to that there will be, and that's what our policy says, is that, you know, it spells out what happens in this community, and it's going to be slightly different for each community, just in terms of whether you go to the local hospital and that's where exams are done, or you go to the local CAC. But every community has a protocol for this in conjunction with local law enforcement. So I think pointing to that staff in the facility, including health services staff, will be trained on the local protocols in response to sexual assault is appropriate, but expecting that facility staff are going to be trained to assess for sexual assault within the facility wouldn't be appropriate.
I like that. Say it again.
I'm still not sure where we're landing on this. Are we dropping these last two suggestions? We didn't circle back to them. I understand a lot of discussion that's gone on just now, but I'm not sure where we're going.
So I think, let me get a check here. I think we leave policies and, right, this is what I heard. I think policies and procedures for responding to sexual assault in compliance with PREA. I think that stands. I think the second to last, the very last statement, and I might not get Kristen's words right, but it would say health staff shall be trained on local protocols for.
I would say all facility staff, not just
I
specifically
like
for
that
health
even
staff,
better.
but all
Yeah.
facility staff shall
Yep.
be trained on local protocols for the response to, local protocols for the response to sexual assault
Okay.
in the community.
And you could even call out the document that you sent shall be trained on local protocols for examination of sexual assault and child sexual abuse victims. I mean, would that even tie it even closer, and we could make it an incorporate, well, no, it's not, but.
Well,
when-
no, because the local protocol
Got
is,
it,
you
it's
know, the
built on
staff are
that.
trained to that California medical protocol. And if you read through that,